Okay, we are going to begin. Welcome to the second part of the Johns Hopkins London School of Economics Conference on Experimental Insights from Behavioral Economics on COVID-19. This is Mario Machis from the Johns Hopkins Carey Business School and the Hopkins Business of Health Initiative. Also on behalf of Matteo Galizzi from the Department of Psychological and Behavioral Science at the London School of Economics, welcome. Today, we will have two contributor sessions and two keynote speakers, Professor Katy Milkman and Professor George Lowenstein. And we also have about 50 pre-recorded 5-minute presentations on the conference webpage, spanning a wide range of topics. And I encourage everyone to browse through them and watch those that catch your attention. These are short, nice 5-minute talks. If you want to know more or have questions for the presenters, there is a link to their webpage where you can find their contact information and often the full paper. Before we begin though, I would like to thank Jamie Longden, who is a Senior Administrative Coordinator at the Bloomberg School of Public Health and at HBHI. And she did a fantastic job coordinating and making sure that the technology works smoothly. Thank you very much, Jamie. Okay, Matteo Galizzi will now introduce the first session of the day.
Thank you. Welcome back. Really looking forward to the exciting talks today. The first contributing session is chaired by Professor Glenn Harrison. Professor Harrison is the CV Star Chair of Risk Management and Insurance and the Director of the Center for Economic Analysis of Risk at Hopkins College of Business, Georgia State University. He's also in the Scientific Advisory Board of the Behavioral Experiments in Health Network that supports this conference. Thank you very much for chairing this session.
Okay, thanks, Matteo and Mario. Just a word of procedure where each speaker is going to be having 15 minutes. We're more than happy to collect questions in the chat room. And if something absolutely burning comes up, I can ask it as the speakers are presenting, but I will tend not to do that because 15 minutes is very brief. But we will be discussing the questions in the chat room at the end, so we'll try to get to all of those. So without further ado, first speaker is Molly Crockett from Yale University, Moral Dilemmas and Trust in Leaders During a Global Health Crisis. Molly. With a cast of 1,000.
Can everyone see my slides and hear me?
Yes.
Wonderful. Thank you so much for inviting me, and thanks to my very long list of co-authors to present our work on moral dilemmas and trust in leaders. Moral dilemmas are situations where the right course of action is unclear because different moral principles give different answers. Unfortunately, over the past year, the COVID pandemic has raised several moral dilemmas. For example, whether to prioritize young and otherwise healthy people over the elderly or people with chronic illnesses when allocating scarce medical treatments. Dilemmas like this one pit utilitarian principles against other non-utilitarian ethical principles. Utilitarian theories judge the morality of actions solely on the extent to which they impartially maximize the welfare of all sentient beings. Utilitarians would argue that younger people should be prioritized over the elderly for scarce medical care because they're more likely to survive and have more years of life ahead of them on average. In contrast, non-utilitarian theories, including deontological theories, argue that morality should consider more than just consequences, including notions of rights, duties, and obligations. Non-utilitarians on deontological grounds could argue that everyone has an equal right to receive medical care, and therefore it is wrong to prioritize some people over others. Over the past year, many hospitals have taken a utilitarian approach to rationing medical care, sometimes resulting in public outrage. This dilemma was first seen in Italy last year and continues to be a problem around the world as hospitals are facing more and more cases of COVID. These are just a few headlines from the past 4 weeks in London, Arizona, and California. Leaders who have to make these kinds of difficult decisions might have a problem. Because we know from past research that trust in leaders is a crucial determinant of compliance with public health guidelines. And there is some evidence that people who endorse utilitarian solutions to sacrificial dilemmas like this one are trusted less. But it's also not the case that all utilitarians are mistrusted. Trust in utilitarianism also depends on what aspect is under consideration. And there are, in fact, two dimensions of utilitarianism that are psychologically distinct: instrumental harm and impartial beneficence. The ventilator's dilemma concerns instrumental harm, and this taps the extent to which people regard harm to innocent people as a morally acceptable means to achieving the greater good. But the second dimension of impartial beneficence might have a very different effect on trust in leaders. Impartial beneficence is the extent to which individuals endorse the impartial promotion of everyone's welfare without regard to distance or personal ties. One example of impartial beneficence in the pandemic is sending scarce medical supplies to where they're needed most around the world, rather than reserving them for one's own citizens. And many leaders globally have endorsed impartial beneficence for sharing vaccines and medicines. However, Donald Trump violated this principle last year when he ordered the US government to buy up all of the global stocks of the COVID-19 treatment remdesivir. He faced widespread public outrage when he did so. And this was consistent with some recent findings from our group that people are sometimes less likely to trust leaders who reject impartial beneficence. So to summarize so far, the COVID pandemic raises a number of moral dilemmas that pit utilitarian principles against other ethical approaches. And past work suggests that people will distrust leaders who endorse instrumental harm, but prefer leaders who endorse impartial beneficence. But we were hesitant to generalize from this past work to the present crisis for several reasons. First of all, past work has relied on highly artificial moral dilemmas that most people have not encountered in their daily lives. So the findings of past studies might not generalize to the context of a global health crisis where everyone around the world is directly impacted by these moral dilemmas that have arisen during the pandemic. Second, most previous work on this topic of trust in utilitarians has focused on trust in ordinary people, but there's a little bit of data suggesting that utilitarianism differentially impacts trust in leaders relatively to ordinary people. And finally, past work on trust in utilitarians has been conducted in just a handful of Western populations, the US, Belgium, and Germany, in students and in online convenience samples. And so these results might not generalize to other countries that are also affected by the COVID pandemic and other sectors of the population. So we decided to test our hypothesis in a pre-registered study across 22 countries on 6 continents, shown here. Over a period of 4 weeks in November to December 2020, we collected data from around 24,000 participants, recruiting samples that were nationally representative for age and gender where it was feasible. And this was only possible through a massive collaborative effort with more than 30 co-authors around the world with expertise in psychology, philosophy, political science, behavioral economics, communication studies, management, and public policy. And I want to especially highlight in particular the contributions of Jim Everett and Clara Colombato, who are here at the session today, who are joint first authors on the registered report and have been absolutely brilliant in guiding this work forward. So the results I'll show you are not yet published, so please don't share them on social media or out of context. In our experiment, participants were randomly assigned to read about leaders who endorsed either utilitarian or non-utilitarian policy solutions to several moral dilemmas that had arisen during the pandemic. Then we measured trust in the leaders. We also measured and controlled for participants' own policy preferences on each dilemma, so we could make inferences about the causal impact of the leaders' positions on public trust over and above just merely agreeing with the leader's position. Now, there are many moral dilemmas potentially relevant to the COVID crisis. And so we chose to focus on 5 in particular because they had been actively debated in public at the time of data collection. They could be realistically applied across all of our countries, and in some cases not actually implemented as strict policy, because for some countries, we didn't want to put participants in the position of potentially disagreeing with their governments. This was a bit of a moving target because the pandemic situation was rapidly changing everywhere as we were designing the study. So we really had to keep track of public debates and policy changes around the world to make sure that all these criteria still held as we prepared to collect our data. Okay, so we had 3 dilemmas that tapped the dimension of instrumental harm. The ventilators dilemma, which I opened with, whether younger individuals should be prioritized to receive medical care over older individuals when resources are scarce. We had a contact tracing dilemma concerning whether it should be mandatory for residents to carry devices that continuously trace their movements, allowing the government to identify people who could potentially be exposed. So this is pitting the right to privacy against the sort of greater good for the public health. And finally, a very particular lockdown dilemma concerning whether to consider reopening schools and some businesses after a prolonged lockdown that was causing a lot of suffering in the public. Now, there are, of course, many different variations of each of these dilemmas that have implications for what utilitarianism would prescribe. And so I just want to say here that we wrote each of these dilemmas in a very specific way, working with philosophical experts in utilitarianism to make sure the critical assumptions held. And I'm happy to share the specific wording in the Q&A if people are interested. Okay, so then we had 2 additional dilemmas that tapped impartial beneficence. The PPE dilemma concerns whether personal protective equipment manufactured within a particular country should be reserved for that country's citizens under conditions of scarcity or sent around the world where it's needed most. And then the medicines dilemma was a similar structure, whether a novel COVID treatment developed within a particular country should be delivered with priority to that country's citizens or again shared impartially around the world. And again, we wrote these dilemmas in a very precise way so as to uphold the key prescriptions of utilitarian theory. Okay, so after reading about the leaders, participants completed self-report and behavioral measures of trust. Our self-report measure was pretty simple. Subjects rated their general trust in the leaders, both in terms of an overall character judgment, as well as how likely they would be to trust this person on other issues. We averaged responses to these 2 questions into an aggregate self-report measure. In addition, we developed a new incentivized behavioral measure of trust, which was a voting task where participants were invited to vote for a leader to be responsible for the charitable donations of another group of participants. So to set this up, we invited a group of online participants to make a donation to the charity UNICEF. And then we invited a second group of voter participants to vote for a leader to be responsible for the group's donations. And crucially, they had to choose between someone who endorsed a utilitarian or a non-utilitarian solution to one of the pandemic dilemmas. Based on their votes, we then actually selected a leader who had the option to transfer this group's donation in full to the charity, or they could embezzle some of the money for themselves. So for the results I'm going to report here, we're focusing on the behavior of the voter participants because we're interested in behavioral preferences for utilitarian versus non-utilitarian leaders. We pre-registered 2 hypotheses, one for each task. For the self-report task, we predicted that participants will report higher trust in leaders who reject instrumental harm but endorse impartial beneficence.
You have 5 minutes.
And we tested tested this hypothesis with a linear mixed effects model controlling for demographic variables and participants' own policy preferences. For the voting task, we predicted that participants would be more likely to vote for leaders who reject instrumental harm and endorse impartial beneficence. And we proposed to test this with a binomial mixed effects model, controlling again for demographic variables and participants' own policy preferences. As a secondary analysis, we also pre-registered a linear model, which some statisticians had recommended for experimental studies of this kind. Okay, so here are the results for the self-report task, aggregating across countries. The data supported our hypothesis. You could see trust is higher for leaders who reject instrumental harm, but endorse impartial beneficence. And here are the results broken down by specific dilemma for instrumental harm on the left and impartial beneficence on the right. The pattern is highly consistent across the dilemmas, and our pre-registered model confirmed robust support for our hypothesis. And here now are the results from the voting task, again, aggregating across countries. And here again, the data support our hypothesis. On the left, people are more likely to vote for the non-utilitarian leader in the case of instrumental harm, but the utilitarian leader in the case of impartial beneficence. And again, the results are highly consistent across dilemmas. So for all three instrumental harm dilemmas, people prefer to vote for the non-utilitarian leader, and for the impartial beneficence dilemmas, they prefer the utilitarian. Our pre-registered binomial model confirmed robust support for our hypothesis. Our linear model failed to pass our Bonferroni corrected significance threshold of 0.025, so we followed up these two pre-registered models with a number of exploratory regressions with different link functions and different specifications of fixed and random effects. And as you can see in this table, the results are highly consistent across models, with effect size estimates ranging from 18 to 33% of voter share differing across dimensions of utilitarianism. Finally, we conducted exploratory analyses testing variation in effect sizes across our countries. So here I'm showing country-level model coefficients for the interaction between dimension and leader argument in the self-report task. And nearly all the countries we tested are showing a positive effect, although you can see there is some variation across countries. Same deal for the voting task. Pretty consistently positive effect across countries, but there is some variation. And finally, here is the correlation between country level effect size estimates for the self-report task on the x-axis and the voting task on the y-axis. So each dot is a country, and you can see the self-report and behavioral results are quite consistent across countries. So these data suggest that the effects of utilitarianism on trust in leaders are fairly universal across the cultures that we tested, but we are also still exploring these data to investigate potentially systematic cultural differences in terms of their variation. So thank you for your attention, and I'd just like to thank my co-authors, who are too numerous to name individually, and our funders, including the Yale Tobin Center, Lever Home Trust, and Wellcome Trust. And thank you again for your attention.
Wonderful, wonderful. And we've had a very active chat session, and Jim Everett's been responding to many of the questions. We'll get back to that at the very end. I've got 1 minute left, so I will ask a quick question. At the very beginning, you said people have a view of distrust leaders who endorse instrumental harm and so forth. It's very clear that what you meant is some people do that, not necessarily the average in some statistically significant sense. And because even though I may personally despise Trump, there's apparently some millions of people who don't despise him. So how does the heterogeneity affect your inferences?
Yeah, so I mean, I would hesitate to generalize from the example of Trump to this program of research. However, I think two responses. One, we do control for individual policy preferences, even though there is a positive effect. So of course, people are more likely to trust a leader who endorses a moral position that they themselves agree with. But we show that over and above that, there are systematic differences in trust in utilitarian leaders according to these two dimensions. The other thing I'll say is that some of our past work showed that distrust of utilitarians is particularly driven by individuals who do not subscribe to utilitarian morality themselves. This is an effect we're exploring in our data, and I believe we do see results consistent with that, but those analyses are ongoing. So.
Great. And my apologies for mentioning Trump, but I was picking up on your reference to him.
Of course, yeah.
Okay, let's move on. Let's move on now. Thank you so much. Let's move on now to Lorenz Goette from University of Bonn and National University of Singapore. Does information about local COVID-19 incidents increase the use of digital contact tracing apps? Lorenz.
Yes, thank you. Thank you very much for having me. And again, thank you to Matteo and Mario for setting up this fantastic workshop. So like Glenn said, I want to talk about how can we motivate individuals to use digital tracing apps. And this is a joint project with Zihua and Simon, who are both also here this, well, for me, it's evening, because I'm in Singapore right now. So what is the motivation for this research? Well, the research starts from the observation that now epidemiology has determined pretty quickly that sort of conventional paper and pencil contact tracing, as we used to do it for many other diseases, simply isn't going to be able to keep up with the novel coronavirus, just because it spreads so quickly. However, imagine that everybody installed an app on their phone that can measure when it's close to other phones and how long it's been near these other phones. So then if somebody got infected with the novel coronavirus, it would be very easy to rapidly push out warning messages to everybody who has been near. And in some versions of these apps would even be able to determine whether you should just be careful and stay home, or you've been so close for so long, you should absolutely quarantine and get tested immediately. Then these calculations suggest that might actually be enough to push the R value so low that eventually the pandemic would just die out. Now, uptake of such an app is a classic public good. The benefits accrue to society at large, whereas the costs from perhaps you're being put in quarantine all for nothing, privacy concerns, just the hassle of having an additional app, maybe the app is draining your batteries, they're all private. However, the epidemiologists point out that there is no need that everybody actually needs such an app. We would just need to get roughly about 60% adoption in the population. Now, in Europe and in Asia, there has been a lot of enthusiasm for these types of apps. They have been developed in many countries. And for the countries that have voluntary adoption of these apps, the picture has been pretty uniform, that adoption is significantly below these thresholds that people would think make a real difference. So for instance, in Germany, which is going to be the focus of the digital tracing app that we are looking at here, adoption is at roughly 30% of the population. Okay. So there has been a big spike in initial take-up when the app came out in June, and then there you see very gradual increase in the number of users, but it's been stagnant around the 30%. So we want to ask how could we change this, and to what extent can we change this? And the mechanism that we are looking at here is how about highlighting your local incidence rate of novel coronavirus infections in your neighborhood, to highlight this and to amplify this message with a normative component, where we would also tell you whether your count, it's going to be counties, is above or below the average in your state. Okay. So for this, to address this, we conducted 2 studies. The one that I'm going to mostly talk about today is going to be a large ad campaign on Facebook and Instagram, where we try to encourage the uptake of this app, and I'll tell you exactly how. We'll also have a second study that is a survey study that embeds the same intervention that allows us in more detail to study behavioral mechanisms, but I'm not going to talk about this so much today. So let me jump right into what this campaign looked like. So imagine you're on Facebook and you scroll on your whatever it's called timeline, and then you see this app, which is in the control condition. It's just a standard short video clip that the German government developed to encourage individuals to download the digital tracing app. And it also tries to push this out. It encourages everybody to share their video clip advertising this digital tracing app. Now, how do we change this? Now, instead of just going straight to the video that you can see here, now we add information here about the local incidence rate of the novel coronavirus in the last week in your county. Okay. So Germany is subdivided into 400 counties, and then the next higher level of aggregation is the states. And then we also add here this normative element which says, is your county above or below the state average? Okay. So this, of course, this is not the face of the coronavirus. This is the sad face of the person who is trying to launch the digital trade or is trying to combat coronavirus. So you're above average. It's the sad face that you get here. And if your country was below average in terms of the incidence rate, then you would get here the green happy smiley face. So just to give you a quick overview of what our treatments look like. The control condition is, like I said, the standard short clip to encourage the download of this app that the German government developed. And in the treatment condition here, we simply add this information part that I had just shown you on the slide before. We then also have a third treatment where what we were concerned about is, what if telling as an individual that your county is actually below average, could that possibly backfire in the sense that interest in the tracing app would now fall even below baseline levels? So this is, so in order to counteract this, we have this third treatment condition, which does the following. Now, after you're being told whether you're above average or below average, here, this message here tells you you're above average. To change this, go and download the tracing app. Okay. Whereas if you're below average, the short message here tells you to keep it that way, go download the tracing app. Okay, so let me give you a first look of the overall results. So what we are measuring basically is interest in the ad and interest in the app. And we have two measures here. So one set of measures is how long do individuals view this video. This is the so-called video play rates. And what you can see here in the video plays is that this is the control condition. About 5% watch it for 3 seconds, and then they sort of drop out gradually. Interest is significantly higher in the two conditions where we highlight the local incidence rate. Now, this isn't just confined to watching the video. This is also reflected in higher click-through rates, that is, clicking actually on the link that will lead you to the download site for the digital tracing app. So the average effects clearly positive and large in relative size of the baseline effects, but small in absolute value. I'll talk about this a little more later on. Now, what about the above and below average status of a county. So here we can, and let me focus here on the 3-second video views because you can see it very nicely. Now here we can do a regression discontinuity design where here you have the above average counties and here you have the below average counties. And so the counties just around the average, now they have very similar incidence rates. However, one gets the sad face, the other gets the green happy face. And you can see immediately that makes a big difference for interest in the video. The view rates here, you can see the treatment effect relative to the control group almost doubles here when you're just above the average versus just below the average. So highlighting the information has a positive effect on interest in the digital tracing app. The above average status also has a positive effect on interest in the digital tracing app.
You have 5 minutes.
Thank you. Now, what about more generally the effectiveness of the treatment as a function of the local incidence rates? So the feature of this app is that it is particularly useful when there is a lot of infections going on, right? Because that's precisely when standard contact tracing is just going to be overwhelmed. So the private as well as the social benefits should be higher in environments with high local incidence rates. So highlighting high local incidence rates should have a bigger treatment effect than highlighting low local incidence rates. However, two forces are going to act against this relationship. So one is information avoidance, highlighting that you live in a county with a very high local incidence rate may be a scary thing. And so looking away and ignoring the treatment now is one way to avoid engagement with this fact. And so that could work against higher effectiveness when local incidence rates are high. More generally, it could also be not more generally, but differently, it could also be the case that regional differences in demographics that lead to higher or lower local incidence rates could also be associated with the effectiveness of the intervention. So think of it basically as regional variation in carelessness. Okay? So very young urban counties are gonna be predisposed to have higher incidences of the novel coronavirus, and the reason why may just be because they care a little less, and that's also why the app might be less, why the intervention might be less effective on them. So our strategy is to see, can we get a handle on these regional differences and then see what's happening to the variation that is left in the local incidence rates. And the way we do this is by using machine learning techniques to predict in a parsimonious specification the average local incidence rate as a function of regional demographics that are all fixed over time. So that are all like demographic differences between these 400 counties in Germany. And then that allows us to decompose the incidence rate into a predicted county average that is a function of its demographics and a time-varying residual. And then we interact both of those with the experimental treatment to see which component of this variation responds to our treatment and how. So, and then we have to worry about standard errors, but I'm gonna skip that because I only have, I think, 2 minutes left. So now let me show you what we find. So first of all, what we find overall, we find that our treatment interacts with the local incidence rate, but exactly in the way that you don't want it to interact. So counties with a high local incidence rate, they show less responsiveness to highlighting this. And when you look at why, it's entirely driven by differences in these predicted incidence rates due to differences in demographics between counties. So it's entirely the demographics that lead to higher incidence rates that also cause this lower effectiveness of our treatment. When we look at how the treatment interacts with the residual time varying component of local incidence rates, there, if anything, we find a positive interaction effect. I would have some regressions to show you, but no time. So let me wrap up. So just to say it again, what we find overall is that highlighting local incidence rates increases interest in a digital tracing app. But we do find this worrying interaction that precisely those counties with the highest predicted incidence rates respond less to the experimental intervention. We find that labeling a county as above average helps for the take-up of the digital tracing app. And while we find that our treatment effects are large in relative terms, in terms of the baseline interest of the app, the baseline interest of the app is very, very low. I'm going to skip my remarks about the effectiveness, and I would like to conclude on a pessimistic note. So now to think about what can we learn from this, also perhaps for other interventions that might help us end the pandemic. This result that we find that precisely those groups with the highest incidence rates, which are really the ones that you want to participate in everything, in taking digital tracing apps, in getting vaccinated, and in practicing social distancing. Now, the fact that here already, we find that they don't respond to the tracing app. We also find in our survey that all of these behaviors are super correlated. So, this, in my view, gives us a relatively bleak outlook to whether or not behavioral interventions can really make a big difference in changing also these other behaviors. So while we see that the mechanisms are all there, one of the findings that really troubled me when we did this research was that precisely in those areas where you would expect the highest returns, those are the most resistant to these interventions. Okay, sorry for running over time. That was it. Thank you very much for your attention.
Okay, and we will come back to, because one of the big questions I've got from marketing is a big distinction between the things that get people to adopt a new brand of toilet paper and not the things that get people to stay with that brand of toilet paper. And the behavioral literature seems to be focused on adoption and not paying any attention, it seems to me, about attrition. But we'll come back to that issue. But we do need to move on to the next paper, which is by Hannah Julienne at the Economic and Social Research Institute in Dublin. Behavioral pretesting of COVID Tracker, Ireland's contact tracing app. I'm looking forward to this because I have Irish co-authors that live in Ireland and talk about Ireland a lot.
Very good. Just to check, can you see my slides and hear me okay?
Yes.
Yeah, okay, great. Yeah, so thanks very much to the organizers for organizing this conference. It's been really interesting. Yeah, so I'm Hannah and I'm a postdoc in the Behavioral Research Unit in the SRI in Dublin. And over the past almost a year now, we've run quite a lot of quite rapid turnaround studies related to COVID and behavioral issues around COVID. And that have at times, not always, fed into government communications and government policy here. So I'm going to talk about one of these studies today, which was our behavioral pretesting of COVID Tracker, which is Ireland's kind of government-backed official contact tracing app. And I'm going to focus especially on the effects of including additional privacy assurances in the app. So Lorenz has very helpfully completely introduced the idea of digital contact tracing. So that's great. I don't have to talk about that. But yeah, as you mentioned, obviously, an issue with these contact tracing apps is that we do need relatively high uptake for them to be successful. Now, the estimates for how many people need to download an app for it to work kind of vary a lot. There's that kind of 60% figure, but then there's also other people that say any amount of uptake is useful. Even if you're not relying on it entirely for your contact tracing, as long as some people are using it, it's always going to be helpful. but clearly the more people that download a contact tracing app, the better. So what this means is in designing a contact tracing app, one has to not only think about the technology behind the app and how it's functioning, but also how people perceive and interact with the app so that more people download and use it. So that's where we came in. So we were brought in to pre-test the COVID tracker app. So the app was developed by a company called Nearform for the Department of Health here. So we worked closely with them in designing the study. And the app itself has three main functions. So obviously the most important one is contact tracing. But there's also a feature in the app that allows users to check in what symptoms they have on a daily basis and kind of keep a record of these. And there's also a kind of updates tab in the app, which provides people with the latest information on the spread of the virus in Ireland. And we actually tested 4 different behavioral manipulations in the study. But today I'm just going to focus on this one here, which was the level of privacy assurance provided in the app, mostly in the interest of time. And also, needless to say, it's where we got our most interesting results. The trial was run in June ahead of the app's launch in July. And I think it's fair to say by international standards, the launch was seen as quite successful here. We had over 1 million people downloading the app in the first 48 hours, which maybe doesn't sound like a whole lot to most of you, but the entire population of Ireland is under 5 million. So it is quite a significant proportion of the adult population that downloaded it immediately after it was launched. So obviously a large part of the kind of conversation surrounding these contact tracing apps has been privacy issues and this idea of governments potentially tracking location and tracking their citizens. And as probably a lot of you know, this led Apple and Google to team up and develop a Bluetooth-based technology for contact tracing, which is, protects users' privacy and keeps them entirely anonymous. But of course, it's one thing protecting users' privacy, and it's quite another reassuring them that their privacy is protected and making them feel comfortable. So we had a look at the literature around this, and what generally seems to be the case is people have fewer privacy concerns and are more willing to share their data if they're assured that their data won't be shared with third parties, if they have a greater perception of control over their data, and if they're given a justification for the collection of their data. But at the same time, there are some studies that show that these kind of interventions can backfire if they confer too much salience to privacy issues. So someone might not have been thinking about privacy, you make them think about it, and all of a sudden they're much more concerned about it. So based on this, we formulated a hypothesis, which we pre-registered, that providing additional assurances about privacy issues should increase understanding of these issues, reduce concern, promote trust, and increase people's willingness to give consent and engage with the app. But we still, acknowledge that there was a risk that these privacy assurances could backfire, which is why we thought it was something worth testing in the study. So I'm not going to go into a whole lot of detail about the outline of the study, just because I don't have time, but I'll just give you a brief overview. So we conducted the study online. We use a piece of software called Guerrilla Experiment Builder, which is what we use to run all our online studies. And what we did is the participants, so they completed the survey questionnaire online on their computer or their tablet, and then they also had their phone with them, which they used to download a trial version of the app. So in this first survey, they first read what we call a call to action, so just a kind of brief introduction to the app and what its main functions are, and we asked them how likely they would be to download it and some other questions to kind of get their first impressions about the app. Then we gave them instructions on how to download a trial version of the app, and they were randomly assigned to receive different versions of the app depending on what experimental conditions they were assigned to. And then we kind of brought them through step by step through the kind of onboarding process of the app and directed them to use different features of the app while responding to the survey on the computer. The participants were then given about 3 to 4 days to use the app as they wished, or not at all if they didn't want to. And after 3 to 4 days, there was a second survey just to get their impressions a few days later, and there's a few other parts of that as well. In terms of our sample, we used a representative sample of smartphone users from an online panel held by a market research company here. And we started out with a sample of just over 1,200 participants. Obviously, there was some attrition as they moved through the study. So when it came to survey 2, we ended up with about, I think, just under 800 participants. And the participants received an incentive of between €5 and €12, depending on whether they completed the first or the second survey. So as I said, I'm going to talk about the privacy assurance manipulation today. So for this, we had participants randomly assigned to one of 2 conditions. So participants in the baseline condition just kind of got the basic wording of the app that the app developers had provided to us. So there is information about data use and privacy there, but it's, I guess, the minimum amount of information they were required to give, by law or that kind of thing. And then participants in the second condition saw exactly the same information. And then there was these additional privacy assurances. Basically, anywhere that was talking about data or privacy, we put in additional assurances. So I think it was probably 4 or 5 screens in the app that had these additional assurances. So just to give you an example of what that looked like. So this is one of the screens in the app about users' data. And this is what a participant in the privacy assurance condition would see. So the statements that are kind of in bold there that I've highlighted with the red arrows, they would only be seen by participants in the privacy assurance condition. So they're things like, reassuring them that their identity won't be revealed to other app users, that no other information is gathered other than that they consented to, that their data won't be used for any other purposes other than fighting COVID-19, these kinds of things. Okay, so get on to some results now. So first of all, we did find that the majority of participants were willing to download the app. So this is when we asked them before they downloaded the trial app, but after they'd been given a short introduction to the app, and we asked them to rate on a 7-point scale how likely they'd be to download the app. 78% responded above the midpoint of the scale. So the feedback was initially quite positive. But when we asked participants for a reason for the rating of how likely they'd be to download the app, almost 1 in 5 mentioned privacy concerns as a reason for their rating. And if you look at this graph here, you'll see that those privacy concerns were especially prevalent among those participants who were least likely to download the app. So for those participants giving a rating of 1 or 2, 3/4 of them were mentioning privacy concerns as a reason for their rating. And something that's important to note is that at the point where we're asking them about this, we haven't mentioned anything about privacy. In the description of the app, we kind of talk about the functions, but there's no mention of privacy there. So this is completely unprompted privacy concerns. Moving on to look at the effect of our privacy assurances, first of all, on trust and privacy concerns. So after participants had kind of used the app for the first time, we asked them how much they agreed with a number of statements related to trust. So they were, I trust I can change my mind and update my data preferences. I trust no other information is accessed other than that I agreed to, and I trust my data will only be used to fight COVID-19, not shared with third parties. And so if you look at the red bars there, that's the participants in the privacy assurance condition, and you can see that trust is slightly higher among those participants than those in the baseline condition. And if we look at privacy concerns, we see an opposite pattern. So we asked participants about any privacy concerns they had at kind of various key points. Is that the 5 minutes again?
That's 5 minutes there.
Yeah. Okay. Yeah. So at kind of key points where they're asked to give consent or share some information, we asked if they had concerns at those various points. So those points would be when they're asked to check in symptoms into the app, when they're asked to provide a phone number, so if they're recorded as a close contact, somebody can give them like a call back with further information. When they're asked to just consent to contact tracing in general, and when they're asked to consent to the use of app metrics, so how they use the app. So here, privacy concerns were across the board lower in those participants who saw the additional privacy assurances. And if you take a combined score for trust and a combined score for concern, we get significant differences here. And what's interesting is if we also only look at those participants that mentioned privacy concerns in that first part of the survey, or if we just look at the participants who are least or less likely to download the app, these statistically significant differences were on the whole more or less conserved. So we're not just increasing trust in people who already trust the app already, we're increasing trust with the people that it actually matters. Yeah, so next I'm just going to show the effects of privacy assurances on consent and engagement with the app, or rather stated consent, I should say. So we asked participants if they consented or shared data, again, at those kind of various key points in using the app. Consent was generally very high across the board, very slightly higher in the privacy assurance condition, and there was a significant difference in terms of the proportion of participants consenting to a callback, so who gave their phone number so that they could be called if they were a close contact. I should point out that all the participants, or sorry, all users would be notified if they were a close contact. This is just to kind of get an extra call. Finally, I'm just going to show the effects of the privacy assurances on comprehension. So we asked participants how well they felt they understood what data is collected by the app, and also what kind of features of their phones are used by the app. And participants in the privacy assurance condition seemed to at least think that they understood this better than participants in the baseline condition. But what's interesting is when you look at actual measures of comprehension, this was not the case. So measured comprehension through 4 questions that were about what data is collected by the app and what phone features are used by the app. And these were the kind of questions they had to like select all correct options from a list. And participants who saw the privacy assurances didn't actually perform better than those in the baseline condition, even though they thought they understood it better. And in fact, they may have performed ever so slightly worse on one of the questions. So they were actually, this was all due to them being more likely to say that IP address wasn't collected by the app when in fact it was, and they were told so when they were setting up the app. So in summary, 1 in 5 participants in our study had privacy concerns about the COVID tracker app prior to its launch, and these concerns were especially prevalent among those participants least likely to download the app. Including additional privacy assurances increased trust and lowered concerns about privacy issues. Participants who saw additional assurances were significantly more likely to share a phone number for contact tracing. Participants who saw additional assurances felt they better understood what data is used by the app, but this was not reflected in actual measures of comprehension. So I guess this kind of raises, an important ethical point. These additional privacy assurances can help people feel more comfortable and feel like they understand how their data is being used more, but you do need to check that you're not significantly impacting on their comprehension and not misleading your app users. But on the whole, I think what is kind of the most important thing about our study is that it shows that behaviorally pre-testing a contact tracing app is feasible and worthwhile, even under considerable time pressure.
Wonderful, thank you. Go ahead,
yeah.
go ahead.
I was just going to say, obviously thanks to the app developers and the Department of Health who worked with us very closely getting the study together. And thank you very, very much to my co-authors. Needless to say, this was very much a team effort getting this study together. And I've just put up our group's webpage there. As I mentioned, we've run, I think we're probably on our 8th or 9th study now since the start of the pandemic, and we do try and keep our webpage updated with publications and working papers if anyone's interested. Thank you very much.
Thank you very much indeed. And we've got about 20 seconds, so I'll exploit that, and we've got some more questions later. Privacy is a deeply important question. And I heard you say earlier that there are some behavioral interventions that had backfired, that this was your words, by making privacy salient. Is that a paternalistic welfare metric that leads you to call that backfiring, or is it an individual? Because it can go both ways. And I think that's actually one of the rich features of your study, is you're studying comprehension and how privacy affects. But we have to, did you mean to say backfire?
I probably didn't think about it too deeply, to be honest. Yeah, I'm not sure.
I guess I'm trying to get people to think carefully about the individual welfare metric rather than, let's nudge them to buy more toilet paper, which is what we're often doing.
I backfire in terms of, I guess generally these the intention behind these papers is to get people to share more information.
Yeah, but the intention is
not
not
necessarily the right thing to do, of course. Yeah.
Right. And actually, that's where I think your study is so exciting, because you're looking at the structure, what will cause privacy to have an effect. Anyway, well, I should move on. It's a good thing if I get excited about all the papers, so forgive me. Okay, let's get to the last scheduled paper, and that is by Armando Meier, University of Lausanne. Anticipation of COVID-19 vaccine reduces social distancing.
Yeah, thanks very much for having me. I'm very happy to present at this conference. So this is joint work together with Ola Andersen, Paul Campos-Mercade, and Eric Wengström. I'm Armando Meier. I'm a research fellow at the University of Lausanne. And the title is kind of a spoiler. So we find that anticipation of COVID-19 vaccines reduces social distancing. Now, we have amazing news with the vaccines coming up. So the vaccines were developed, they're effective, they're safe. So these vaccines potentially mean that, or actually mean that infection cannot just be delayed, but can be entirely avoided. Now, how is that different from example from the first wave? It's different in the sense that at this point, it was not entirely clear whether vaccines will be coming up. So people could have reasonably inferred that when they're careful, they basically just delay infection, but they might not be able to avoid infection. However, with the upcoming vaccines, forward-looking people can actually completely avoid infection. So if they're interested in reducing the risk of infection, they can now hunker down and be even more careful and then potentially avoid infection. So given the vaccines on the horizon, one hypothesis that one could have about vaccine information becoming available, so this good news about the vaccines, is that people become more careful. You can also think about this case is in some ways comparable to a soldier being in the trenches, knowing that tomorrow the war will be over. You would take extra care to not get hurt at this point. And if people adopt this kind of reasoning, then basically what it means is they should be more careful now. However, it could also be that people just think, finally, we're done with COVID-19. The vaccines basically mean that COVID-19 is over and we can go back to our normal lives. I think this quote by Seattle Mayor Jenny Durkan illustrates this thinking well. It's just human nature to hope. I think that people thought that if there was a vaccination, that it would be safe to gather again, and it's not. So many people might think that just by hearing about the vaccines in the news, that the COVID-19 is basically history, or I mean, they might be just more optimistic about the end of the pandemic. In this case, people become less careful. So people think the pandemic is basically over and I don't have to stick to the rules anymore. So these are two ways of how vaccine information could shape people's health behavior. And we don't really know what happens when people learn about the new vaccines and about the vaccines being effective and being rolled out soon or already being rolled out. In the first case, as I've said, infection cannot just be delayed, but can be avoided. If people think about vaccines in this way, then people should become more careful. However, in the second case, when people's intuitive reaction is just finally we're done with COVID-19, then people become less careful. Why is it important to know whether people become more or less careful with vaccine use? Now, it's key for policy making, because if people become less careful, then we might need stricter policies to contain the spread of the virus. However, if people become more careful, then we can keep current policies, or we might even potentially think about relaxing them. So everything else hold constant, anticipation of vaccines and the corresponding behavioral effects are important inputs to understand how effective policies are going forward. Now, to look at what happens when people are informed about COVID-19 vaccines, we do a survey experiment. In this survey experiment, we sampled a representative sample of the Swedish population with roughly 1,600 observations, and we collected the data between December 10 to 13. So this was exactly the time horizon when the first vaccines were actually given in the UK. And we pre-registered data collection and analysis that we conduct. Now, the Swedish setting is relatively interesting for several reasons. One is that there are relatively few mandatory restrictions. What that means is people actually do have some discretion about how to act. And this is important because when we're interested in how vaccine information affects voluntary social distancing behavior, then we need to have a setting where people actually have some leeway in how to act. And I would argue that this is true almost under any policy measures, but it's certainly a bit more free in Sweden at the time of the survey experiment than in some other places. And what's also interesting about the Swedish case is that vaccination attitudes are relatively similar to other Western countries. So in that sense, Sweden is comparable to many other settings that we care about. These make Sweden these 2 points make Sweden relatively attractive to study this question. And what we do here in this experiment is relatively straightforward. So we have an information treatment that we give to 50% of the people before answering questions about social distancing, and the other 50% of the people, they answer the questions about social distancing before getting any vaccine information. So you can think about the experiment basically providing half of the people with vaccine information and then looking how that affects their social distancing behavior, and the other half just answer questions about their social distancing behavior. So what we tell people is that vaccines are over 90% effective. So they know after reading this information that the vaccines are effective. Sorry? Okay, for some reason I thought I heard something. But then we also tell them that vaccination has started in the UK already. And last, we tell them that vaccination start in Sweden is scheduled around the beginning of the new year. So taken together, we tell them about that the vaccines exist, that they are effective, and that they are upcoming in terms of the vaccination start, both in the UK and in Sweden. Then we look at the following outcomes. So we look at 10 intended social distancing and health behaviors. So we have used these questions before in a paper where we link pro-sociality to health behaviors during the pandemic and show that people that are more pro-social are more likely to stick to the public health guidelines. And we use, again, these questions here where we ask people, how much a certain statement applies to them. For example, I will try to avoid social contacts in person. And then also we ask them, if you exhibited mild symptoms of illness, for example, coughing tomorrow, would you self-quarantine? And we have shown previously, and also in this paper, that these responses to these questions strongly correlate with the likelihood of having had COVID, but then also with actual behaviors such as buying masks to protect others. So we have those 10 intended social distancing and health behaviors. And then we also have information about the willingness to participate in a stay-at-home program. In these stay-at-home programs, we vary length, intensity, and compensation of voluntary self-isolation programs across 9 scenarios. And the way you can think about this really is in terms of capturing people's general willingness to stay at home. So what we tell them is the government will basically pay them a certain amount for participating in one of those stay-at-home programs, and we just then use different variation of those programs, and in the outcome that I will show you, we actually average the participation rate across those scenarios. So this really captures sort of an overall willingness to stay at home. So we look on the one hand at these social distancing and health behaviors, and on the other hand, the willingness to stay at home. So just to shortly summarize at this point, so we have the treatment where we tell people about the effectiveness of the vaccines and that they will be rolled out in Sweden around at the start of the new year, and that they've already started in the UK. And we then look at how that affects social distancing behavior and the willingness to stay at home. And this figure shows you the main results. So on the y-axis, you have the different behavioral items, some of them I've mentioned before. And on the x-axis, we have the effect size of giving people information about the vaccines coming up. And we see that, across these different behavioral items, we have a roughly 0.1 to 0.3 standard deviation reduction in people's compliance with public health guidelines. That's both the case when we look at, these different behaviors, such as avoiding contacts, But also it's the case when we ask people, if you exhibited symptoms of illness tomorrow, would you self-isolate, for example, and inform contacts? So across the board, we see that people stick less to public health guidelines when we tell them about the upcoming vaccines. This is quite a robust relationship. Also, when we look at the regression results, here we see the coefficients for providing this vaccine information, both for the estimate for the health behavior index, where we just average across all of these items that I've shown you, and then look at how sort of the average health behavior shifts. And then we can look at the stay-at-home programs as well in columns 4 through 6. And we see, you know, whether we control for gender and age categories or for gender age categories, and controls such as education and income does not matter for the impact of vaccine information on behavior.
You have 5 minutes.
Thank you. Now, why is this the case? So why do we see that people comply less with social distancing behavior? Now, what we can do in the survey is we can analyze how people perceive the likelihood of life going back to sort of starting to going back to normal in February, which is an indicator of how long people think the pandemic will last. And people can answer on a scale from 1 to 7, from strongly disagree to strongly agree that the pandemic that life will be going back to normal in February. And we see for those people that did not get any information on the vaccine, that they are quite pessimistic. So usually people strongly disagree with the statement that life will start going back to normal in February, but we clearly see that there is some heterogeneity across people. Now, this is the figure for people that have no vaccine information. Now we look at people that we provide with vaccine information, and we see that those are more optimistic than the people that did not get vaccination information. So they're less, you know, they're less strongly disagreeing with the statement that life will be going back to normal. So they're slightly more optimistic here across the board, but mainly also among them across the most pessimistic answers. So people seem to be more optimistic that the end of the pandemic is coming sooner when they got information about vaccines. So people think that the pandemic will soon be over because of the good news. Now, if we think back at the beginning where I discussed these two options, that people might think that the pandemic is basically over and that forward-looking people should basically be more careful. So if we had to deal here with sort of, you know, people that just want to avoid infection and they're forward-looking, what this figure should imply is that actually people should get more careful with social distancing behavior because they think the pandemic will be over sooner. However, what we see is that people think that the pandemic will be over sooner, and they also start already relaxing their social distancing behavior. Now, why is that? We cannot use the survey to look much more into detail here, but based on previous research, we know that optimism and good mood reduce perceived risks, leading to more risk-taking. And we also know that we also know that when you describe rewards to people, so when people think that rewards are really great, it makes it sometimes very hard for them to resist the temptation. So on the one hand, there could be an optimism effect here where people are less risk-taking. On the other hand, it might be that people just, you know, want this pandemic to be over so badly that it's really hard to resist temptation when they get news that it's almost over. With that, I would like to conclude. So in summary, we see that vaccine anticipation reduces compliance with public health guidelines. There seems to be a vaccine optimism effect. So people think that the pandemic will be over sooner when they learn about the schedule of the vaccine rollout and the availability of vaccines. In combination with previous literature, our findings suggest that hope or optimism might be drivers for the reduction in social distancing behavior that goes together with an optimistic outlook toward the end of the pandemic. In terms of implications, we think that our findings have 3 implications. One is that vaccine anticipation is sometimes taken up in economic and epidemiological models of disease spread, but oftentimes there is the assumption that people are forward-looking and actually start to be more careful when a vaccine is on the horizon. However, what we show is that people actually start to be less careful when they learn about the vaccines. Then it seems important to highlight that government communication is probably crucial to shaping the adherence to public health guidelines when it comes to also, communicating about the upcoming vaccines. So the tone and level of information seem to shape adherence. So we should really caution also when we communicate with people that it will be a long time until a sufficient number of people will be vaccinated and until they will be vaccinated themselves, to make clear that they still need to stick to the social distancing guidelines. In terms of policy, I've mentioned it at the beginning. So if people become less careful, any given policy will be less effective. So we have to think carefully about which policies to implement and to extrapolate the effectiveness of those policies from the spring to now, because by now people anticipate vaccines and might behave less carefully. What we find is anticipation of COVID-19 vaccines reduces social distancing, which unfortunately, following up on Lorenz's other more bad news. But still, I thank you very much for your attention, and I'm looking forward to more questions and comments.
Excellent, thank you very much. Now we'll just quickly get into the 15 minutes Q&A. Just let me explain for the other 230 people, there's 266 in all. There's a bunch of people who are on the panel, and our sole claim to fame is that we're co-authors of papers that were accepted in this session or the last one. I'm going to call on 3 or 4 of those now for some questions, and then Mario and or Matteo will open it up to some questions from everybody, from some of the chat questions. So we should have plenty of time. We can go until about 3:55 here in Stockholm, so I'm in Stockholm. So the joke about doing a representative sample of Swedes is it's the first 6 people you see when you get out of the airport. They're all the same. I have a quick question from the first paper, a question from a philosopher, Don Ross. Don?
Stop calling me a philosopher. Yeah, so I'm just wondering about the, with respect to the first paper, whether when it comes to moral dilemmas associated with COVID response, whether the utilitarian deontological distinction is really quite the relevant one. I mean, in the sense that, one way a true deontologist might argue is to say, since no one must be used as a means to the consequent to social end, the vaccine should be based on a lottery or something. Whereas it seems to me the actual controversies that have been discussed in the media are more controversies arising within a consequentialist context, right? In the sense, or at least a pure consequentialism versus a kind of morality that isn't necessarily deontological. So, for example, a pure consequentialist might argue that we should prioritize vaccinating the young because they're the ones who are most active and they're the ones who are least likely to socially distance and therefore the most likely to be transmission vectors. So we get the disease in hand quicker if we prioritize them. But that seems to involve a moral hazard. And it also seems, even if people don't understand moral hazard, it seems to involve rewarding asocial attitudes. That seems to be the kind of morally focused controversy we've actually seen, and that doesn't seem to me to clearly cleave along utilitarian versus deontological lines.
Thank you for that question, and I agree with everything you said. I think it's important to separate the normative questions around what ethical perspectives should be driving conversations around these dilemmas in the pandemic, and the descriptive question that we focused on in terms of how endorsing a particular solution to a particular dilemma drives trust in leaders. And we actually developed the dilemmas because we had seen public figures taking a stand on these issues in public in ways that weren't even necessarily useful. And so we wanted to make the point with this work that endorsing particular approaches to dilemmas can systematically affect public trust, totally separately from the question of what is the appropriate response. I don't know if, Jim, you have anything to add there.
No, I think that's right. I would just say that we were very much focusing on utilitarianism specifically, just because utilitarianism has provided some distinctive insights. And there's been some interesting papers, for example, by Julienne and colleagues who have sort of laid out the way that utilitarianism is playing in these dilemmas and the way that as a theory that might help to understand what we should do. And the advantage of utilitarianism here is that it provides such distinctive solutions and it has a very clear baseline. Whereas if we start to consider different ethical theories that can have subtle differences, it's much clearer to differentiate in a clean way across multiple dilemmas, which we wanted to do to kind of get some generalizability in our results, rather than have our results be specific, just say on lockdown, in which there can be different approaches.
Yeah, and just to wrap that up, you know, one of the biggest lessons I think for us from this work is just exposing how complex these ethical issues are to navigate, and that there aren't clear solutions provided by any one theory, which is why I think we're struggling in general.
I think also one of the points that Don was making, Jim, is that utilitarianism is complicated depending on your models of virology and your models of epidemiology. And if you have an extraordinarily naive model of both, then it does provide simple conclusions. But those naive models have changed dramatically during the period. We should move on now. Nora had a question about whether it is actually trust in leaders that we care about here. Nora.
Yeah, from the examples you gave, like the ventilators, this is often ethical boards that decide, or doctors complain they have to decide because the guidelines are too coarse. So in the end, they have to take these decisions they don't want to take. So yeah, indeed, I wanted to ask, how does this relate to the leaders?
Exactly. And this is part of the reason why we wanted to do these studies, is because we saw leaders often weighing in publicly on issues that they didn't have any control over. And our dependent measures in our study were specifically asking about trust in leaders in general, you know, willingness to vote, for control over a public resource, how willing would you be to trust this person on other issues? And so we want to make the point with these data that leaders should consider which issues they do want to weigh in on, because they could impact trust that could damage policy effectiveness on other types of public health announcements not related to dilemmas.
Okay, Nora also had a question on the second paper. This is the one on sequencing effects, Nora.
Oh yeah, Lorenz, I wanted to ask, when you elicited the data, it seemed to be like it was October, and now we are in a very different situation with the mutations coming in and incidence rates maybe higher than beginning of October. So my question is, do you think the intervention could still have a positive impact today, or with the sub-analysis you did, would you be worried that by now it could completely backfire even?
So my interpretation of the evidence is that it's not actually the current local incidence rate that is generating this negative interaction with the treatment effect, but that it's rather the underlying demographics that what I like to think of as sort of carefree attitude towards preventive behaviors that generate both the high incidence rate and the lower responsiveness to the treatment. But I think what would be really interesting would be, I think one interesting element now, back then it wasn't present, would be if we could give some sort of localized information about the prevalence of the new variants, because the new variants, they actually, if there is a variant of the novel coronavirus that is more infectious, then that actually increases the benefits from contact tracing as the infectiousness increases. So I think that would be very interesting to see whether that might actually work better.
Okay, let's. Sorry, you done? Yeah. So let's take the last question from the panel from Phil Fan on the third paper, and then we'll go to the general audience. Phil.
Thank you, Glenn. So this question is for Hannah. So it's more of a clarification question. Did you look at the attrition rate, the dropouts, people who uninstalled the app, and look to see if there was systematic differences between that group and, for example, those who were more skeptical to begin with? And then as well, finally, and maybe this is more of a general comment, I would imagine that for adoption of contact tracing, that there's going to be a systematic relationship to people who are maybe more comfortable with social media. If you're putting yourself out there on Instagram and Facebook and so on and so forth, perhaps your concern over privacy may be on average less than somebody who is not on social media or doesn't care about it. And I wonder if those things were sort of considered in the design of your experiments. Thank you.
Yeah, so on the uninstalling question, we didn't actually have access to participants' data in terms of what they did with the app. So the app was all designed around privacy. So annoyingly for us, that meant we couldn't actually see what they were doing on the app. The only way we could get at it was through the questionnaire. We didn't actually, maybe we should have in the second survey asked them had any of them uninstalled the app. We didn't do that, but we did ask them how often they checked the app in the intervening 3 to 4 days. And I think only maybe 10% said that they didn't check the app again. So I guess it's possible that some of them uninstalled it, but it would have been a small percentage. So I don't know how much we would have been able to get at demographics anyway. Yeah, so I don't think many of them did uninstall it. And in terms of the social media question, we didn't ask anything specifically about social media. We did ask people about their privacy concerns, both when they're online in general and when they use apps, and that was correlated with how likely people were to download the app in the first place, or how likely they said they would be to download the real app. But the biggest driver of whether people would be willing to download the app was their trust in the government. That was by far the most important factor. Also, general anxiety about the pandemic.
Great, thanks. Let me hand over quickly to Mario and Matteo for some open questions from the group.
Thank you very much. Thank you to all the speakers. We have a question from Lucia Reich from Copenhagen. With regard to the app design, would it be much more efficient to change the default of the app to sharing positive results with others and hence with your neighborhood instead of opting in?
Which app are you talking about? Which app are you talking about? The second paper, third paper?
Yeah, I guess the two apps paper.
I know.
I didn't quite get the question there. So the difference between sharing, so at the moment you have to input whether you test positive, and the alternative would be what? I'm not sure what the alternative would be. Say again?
Sharing positive results with others instead of an opting in.
What would the...
Oh, the question is, so there's one decision to opt in, yes or no, and then there's another decision to actually declare yourself positive.
Oh, yeah, sure.
Yeah. It's like, it goes back to the old HIV issues about declaring, I mean, that's the same set of issues there.
Yeah.
Yeah, I mean, obviously that's not something we tested in this study. I mean, that would have been a lot more complicated, I guess. We'd have to deal with participants who actually tested positive, yeah. I think we did ask them how willing they would be to share that information. And I mean, the fact that I can't quite remember what the results are means that we obviously didn't find any significant results in terms of the interventions. Yeah.
Thank you. And we have a question also to Lorenz Goette, whether you can say something more about what attributes you actually found to be predictive of carelessness. A question by Daniel Schnur.
So I gave it the interpretation of carelessness, right? So really what we do is, we use all kinds of demographic characteristics of these counties. So, age structure, population density, education, urbanization, and use this to predict the incidence rates. And we find that it is really this predicted component of the incidence rates that negatively interacts with with the effectiveness of the treatment. But calling it carelessness is, I mean, I intentionally wanted to give it a pretty strong interpretation, precisely to to spur a discussion on this topic.
Mario?
I think, yes, thank you so much once again to all the presenters, to Glenn for chairing, and to the members of the audience for their questions. We are going to end the session, and we're going to take a 5-minute break, and I will be back at 10 a.m. Eastern for Katy Milkman's keynote. Once again, thanks to
Thank you to everybody.
Starting the record. Okay, welcome back. It is a great pleasure for me to introduce our first keynote speaker today, Professor Katy Milkman. Katy Milkman is a professor at the Wharton School of the University of Pennsylvania. She's the former president of the International Society for Judgment and Decision Making and associate editor of Management Science. She's co-founder and co-director of the Behavior Change for Good initiative. She's also host of a popular behavioral economics podcast, Choiceology, which explores key lessons from behavioral economics about decision making. I highly recommend it. Professor Milkman published extensively in high-profile journals, and her work focuses on ways in which ideas and tools from economics and psychology can be used to change behavior, from saving to exercising to vaccination take-up, among many other behaviors. She won many prizes for both her research and her teaching, but she doesn't just do academic work. In addition to the podcast, she worked with or advised many organizations, including the US Department of Defense, the American Red Cross, and Walmart, among many others. She also writes regularly about topics related to behavioral science for the Washington Post and Scientific American, through Intellectual. And finally, she also has a forthcoming book, How to Change, the Science of Getting from Where You Are to Where You Want to Be, which I understand will be released in May this year. Welcome, Professor Milkman. We have 1 hour in total. We're flexible. We would like to leave some time at the end, 15, 20 minutes for questions from our participants, and also questions that I will be collecting from members of our audience. Katy, again, welcome.
Thank you, and thank you so much for having me. Thank you for the lovely introduction, Mario. I'm excited to be here and sharing some really fresh data, as well as some older data, talking about how we can potentially use behaviorally informed messages to help encourage vaccination. And I'm going to be talking mostly about work we did on the flu, but we very much hope that the insights are translatable to COVID-19. And in fact, a lot of the research I'm going to present, that was really the intent all along, was to generate insights that we could apply to COVID-19, and just thinking about the flu as a proxy. As you can see from this introductory slide, I have an amazingly long list of collaborators. And I just want to acknowledge that what I'm sharing today is far from my own work. It's really been a true, I'll say, privilege to work with an incredible group of people. So thank you to the team at the Behavior Change for Good initiative and the many scientists who have entrusted us with your great ideas. I hope I'll do justice to it. Okay, so let me dive right in. And I think this graph that I'm showing, in fact, it may have been shown before. I'm not sure. I should say I haven't been able to attend all of the talks in this conference, which has been a real disappointment. I don't have full childcare at the moment. In fact, I'll warn you that there's a 5-year-old in the background watching Netflix because his grandparents, who normally provide childcare, we've been in their pandemic bubble, are getting their vaccine today. So very exciting reason that I could be interrupted. But anyway, we'll see if I have a BBC Dad moment. So you might have seen this graph before. I think it's really, really interesting to see the way that Americans' willingness to receive the COVID-19 vaccine has changed over time. Obviously, there were big concerns about politics and whether this was being politicized around September, but thankfully we've seen a nice increase in people's willingness to receive the vaccine over time, but still we'd like it to be higher, and we want to make sure that every person who's willing does actually follow through and get the vaccine, and that's what I'm going to be focusing on today. So there's two challenges as I see it to this vaccine problem. The first challenge is persuasion, getting people comfortable, trusting that these vaccines are truly safe. That is not what I'm actually going to focus on today. I think that's a huge challenge. I know many other fantastic groups are working on this. My team has been focused more on the follow-through challenge. So once you are comfortable with the idea of getting the vaccine, how do we make sure you actually follow through and do get it? Because many people say they'll do something or intend to do something and then fail to follow through. And you might think with something like a life-threatening illness, that wouldn't be the case, but we really haven't seen any exceptions to this rule that follow through as a challenge, even when it comes to life and death decisions like cancer screenings and so on. So this is just a graph to motivate that challenge. A few different settings where we see that intentions don't tend to line up well with our behavior. These are the rates at which people in different studies actually followed through when they said, I absolutely intend to do this. You see that there's a big action intention gap. And we're going to focus on how can we close that action intention gap. So again, I mentioned at the outset that what I'm going to be talking about today is using the flu vaccine as a proxy. And it turns out just half of Americans get a flu vaccine each year, even though it's recommended for virtually all Americans. And so we think this is a nice proxy. We actually, my collaborators Mitesh Patel and Angela Duckworth, who are the co-PIs on a lot of the work I'll be talking about today, wrote a piece in June in USA Today talking about the parallels between these two vaccines. Obviously, there are lots of differences as well. I don't want to understate that, but there are a lot of parallels in terms of the rates at which people feel comfortable and say they intend to get a flu vaccine. It seemed like it was an opportunity, just as Operation Warp Speed was sort of gearing up and focusing on let's find vaccines that work and let's find vaccines that we can transport and figure out the supply chain issues. We felt like there was a challenge in figuring out, well, how do we make sure we get the behavioral science right on making sure people follow through if they plan to get a vaccine? And also there was a persuasion challenge. So we wrote about the opportunity to use the fall 2020 flu season as a test bed for different behavioral science interventions that might then be ported to COVID-19. And I'm going to share a bunch of that work today. Before I get into the new work that we did that was motivated specifically by this, I actually wanted to talk briefly about a paper I wrote about a decade ago that really sparked my interest. It was sort of the first project I'd done on vaccination and made me confident that behavioral science could be used to help with follow through. And I think the insights from that work are also relevant to COVID-19. This was a project specifically focused on workplace flu shot clinics, where we said, can we boost follow through? There are lots of workplaces that were having vaccine clinics. And by the way, I certainly hope that we'll see as distribution challenges and supply challenges decline, that workplaces will start holding these kinds of clinics for COVID-19 in the months ahead. And so I think there are probably lessons from this as we get to that point in the rollout. So we wanted to increase take up, and we partnered with a company called Evive Health that specializes in sending reminder mailings to the employees of its partner companies, encouraging them to follow through on different healthy behaviors at appropriate points in time. So this is a mailing they typically sent around flu season saying, hey, here's some facts, you should get the flu shot. And by the way, here are the dates and times when there's going to be a free flu shot clinic at your workplace. And they sent these reminders in this particular study to remind people to get flu shots in the fall of 2009. And we ended up partnering with them on, and when I say we, I should say this is joint work with John Bashir's, Bridget Madrian, James Choi, and David Leibson. And we partnered with this Midwestern utility company to nudge as many of their employees as possible to come and get these free flu shots. At this time, actually, the CDC had not yet recommended that everyone in America get flu shots, so that the recommendations changed the following year. At this point, it was just recommended for those over 50 or with chronic diseases. And so that's who we targeted in this experiment. The company that we were partnering with actually had 62 different work sites, all with different clinics that were open 1 to 5 days. So some clinics were 1 day, some were 3, and some were 5 days. And that was detailed. You got a personalized mailing about the clinic at your work site. So that actually introduced some interesting variation that I'll talk about. So we specifically decided we wanted to test whether or not we could improve the follow through on getting a vaccine by embedding what I call a planning prompt, which is really just sort of using an implementation intentions nudge to encourage people to form concrete plans. So if you're familiar with the literature on implementation intentions, this will look very familiar to you. We basically were piggybacking on this research showing that if you get people to form plans of the type, when situation X arises, I will implement response Y, then the desired behavior gets linked to a concrete future moment and people are more likely to follow through for 3 reasons. So the research suggests first, procrastination is more difficult because now you don't have a vague intention, but rather an explicit commitment. Second, you're less likely to forget because you've thought more deeply about it and actually linked a cue to that action that you intend to take. So cues are how memories are triggered. And so basically you've created a reminder for yourself at the right moment. And finally, thinking about it in advance, thinking about the date and time helps you think about potential obstacles like, do you have childcare? Which is salient to me at the moment, and making sure that's taken care of in advance. Okay, so the control condition in our experiment was that mailing I just showed you with that little blue box, and it just let people know the dates and times when people could get a flu shot. And by the way, there's research showing just sharing this kind of information significantly increases follow through on vaccination. So just that information is valuable, but we wanted to see if we could do better by adding planning prompts. So we tested 2 additional experimental conditions. The first was a date plan condition where we simply told people that many people find it helpful to make a plan for getting their shot, and you can write yours here. And employees were invited to choose a date when they intended to get a flu shot. I should note that this particular intervention didn't make sense at sites that had 1-day only flu shot clinics because there's only 1 date to pick from. So you'll see in our random assignment that we didn't randomly assign people at those sites to this particular experimental condition. So we have a somewhat unusual random assignment algorithm. Not that unusual, but anyway, it leaves out a small subset for that condition. And then our time plan condition, which is the group we expected to work the best, was asked not only to choose a date and time when they would follow through, but also, not only a date, but also a time. So we asked employees to choose exactly when do you intend to get a flu shot. And we randomly assigned all the employees who had indications for a vaccine based on the CDC to these different experimental conditions. So that was 3,272 employees across these 62 work sites. And as I mentioned, there's a slightly fewer in the date plan condition because some of the sites had 1 day only, and it was not appropriate to ask them to choose a day. Okay, so how did this work? Well, the good news is we see a significant difference, about a 4 percentage point increase, 13% increase if you do it as a percent. So nice and substantial from randomly assigning people to be prompted to write down the date and time when they intend to get their vaccination. So we felt really good about that. This is, costless change to these mailings that were already going out that could make them more potent. But we wanted to know a little bit more. So let me dig in slightly more and tell you a couple interesting additional findings before I get to the stuff we did this fall. First, we were really worried about displacement. So what if all we did with these mailings is just get people to come in and get a vaccine at work who would have otherwise gone and gotten one at their doctor's office or at CVS? So a really nice feature of our data set was that a bunch of the people in our study were members of a PPO plan, which allowed us to get their claims data. So we could actually see if they then, made an insurance claim to get to cover a flu shot received at, say, a CVS or Walmart or Walgreens or at their doctor's office. And when we analyze that group, so on the left, you can see this is the workplace vaccination data. And by the way, the date plan and time plan were actually slightly more effective in this subpopulation. So that's a whole other sort of interesting, dimension, like maybe these are people who are slightly more health conscious and that's why they chose a PPO. So we have slightly bigger treatment effects in this population. But then on the right, what you can see is looking at any vaccination. So we're looking at the effect of being assigned to these different treatment conditions on whether they got a vaccine, not just at the workplace clinic, but at some other place like their doctor's office or their, a local pharmacy, and you see the effect sizes are very slightly diminished. So maybe there's like the tiniest bit of displacement, but only very slightly. Essentially, we see the same effect. So it doesn't seem like we're bringing people in to get a vaccine at a workplace who otherwise would have gotten it somewhere else, and we're just shifting where they get it. It seems like we're actually substantially increasing vaccination. So that's really exciting. Okay, the one other big result I want to share from this that I think is interesting is that the effects, we split our sample to look at one-day clinics versus multi-day clinics. So obviously this is, not randomly assigned. There's differences in these work sites besides this, but really interestingly, the effects were very clearly driven by the one-day clinic sites. And I think that's important. These one-day sites are places where you'd be particularly worried about forgetting if you don't show up on that one day. And if you procrastinate or forget, you're out of luck, right? You're not going to get it at your workplace. Whereas the multi-day clinics, if you're a little sloppier with your time management, you can still make your way in. So I do think it's important to note this planning prompt seems to be most potent in settings where there's a limited time opportunity. So as we're thinking about COVID, to the extent that there are limited time opportunities, a one-day drive that's in a local inconvenient environment or at your workplace, that's where I think planning prompts are likely to be most valuable, when it's sort of like available every day at your local pharmacy, which will be the case. And that's what we're trying to encourage in a lot of settings. We may want to look to other messaging techniques that may be more useful. Okay. So we have one insight here. And by the way, I realize I've been talking for a little while, and I am happy to be interrupted if anyone wants to type anything into chat or has questions, because I realize talking at you for an entire hour might make all your heads explode. But so feel free to enter, and I'll try to keep an eye on the chat and the question and answer if you want to stop me at any point. But I am planning to sort of move on to the second portion, which is sharing some fresh data at this point. Okay, so I don't see any burning questions coming up except extrapolating. Okay, let's see. What would you consider more valid insights to extrapolate for COVID-19 vaccination behavior? Common flu or Spanish flu? That's an interesting question. Well, let's see what you let me say, I think what we've done and what I'm showing you, most of these things, my guess is that they should extrapolate just fine, because they're so focused on this intention action gap. I think if we were focused on persuasion, trying to convince you that this is safe or that this is important for your longevity, that a pandemic and a regular flu season might feel further apart. But one of the reasons that I'm focusing on messages that were really more about that action intention gap is I think that's likely to be very similar. But it's a great question. And if I were guessing, I'd say probably a pandemic would extrapolate better to a pandemic, but my hope is what we're doing here is really quite portable. But I'm curious, I mean, lots of caveats to that. We don't know for sure. We'll never know for sure until we test with COVID-19 too. Okay, so we were motivated by thinking can we generate more insights about closing this vaccine action intention gap and really fast? And so that's what I'm going to talk about now. And specifically, we felt that this was a problem right for what Angela Duckworth and I have started calling a mega study. And I'll explain what a mega study is, but you can kind of see here, it's a really, really big randomized controlled trial. Instead of testing one idea like we did in the study I just showed you, where we were thinking about, can we nudge vaccinations with implementation intentions and planning prompts, we said, what if we tested a lot of things at once and got a lot of answers back quickly, given the urgency of this problem? So a mega study is just a very large field experiment in which many different ideas are tested simultaneously. And I'd argue it has a bunch of benefits over our standard sort of one study at a time approach, different research teams each doing their own thing in their own populations. A nice thing about a mega study is it allows for comparability of results across studies. So instead of having to compare my study run at a Midwestern utility firm with another study run with Medicare beneficiaries, we can nudging them to get vaccines anywhere instead of at the local or at their workplace clinic. Everybody's in apples to apples, and we don't have to wonder well, are they comparable? Are these effect sizes similar? So we think that's a really important aspect of this. We can run it as a tournament and draw from lots of different disciplines, because sometimes it's difficult to get economists and psychologists to collaborate on a specific idea, but we could get them both to create their own sort of studies that are embedded within a bigger study, and then they can publish their individual results in their individual preferred journals, but at least there's some cross-pollination there. It obviously vastly accelerates the pace of scientific discovery, and you can have one central organizer bearing the fixed costs. And it's also ideal for machine learning applications, thinking about questions like what works best for whom, because you have many different options and you can see which subpopulations respond best to what in this very wide set of treatment space, in this very wide treatment space. I just want to note that a similar idea sort of to running mega studies has revolutionized AI in the last 15 years or so, and that's called the Common Task Framework, where researchers will compete to solve the very same problem, subject to the same validation method, and using the same data set with transparency in terms of hypotheses tested and results. And I think, you know, we try to do this when we use like common paradigms, like a prisoner's dilemma framework or something in experimental work, but that's different because you don't have random assignment of experiment, you don't have the same validation method because it's different people at different points in time being randomly assigned to conditions. And we know populations and time can make a big difference in results. So we're inspired by that common task framework and also by scientific tournaments, which I think are similar in flavor, but typically don't involve random assignment. So we're going to try to sort of blend the best of both of those in this mega study approach. And I'm going to talk about how we did that with two different partners here. So I'll share results from a mega study first that we did with Penn Medicine and Geisinger, which are two large US health systems with millions of patients. And then I'll turn to mega study results from Walmart, which are literally were released for the first time to the public, both of these yesterday. So it's very timely to get to be sharing these with you. And let me just pause for a second because I am seeing there's a couple more questions, and let me see if any of them are things I should address now, or if we should just keep plowing forward and come to them in a little bit. I'm all for opt-in, excuse me, all for opt-out over opt-in, and actually love that. Hold that thought because you're going to see what we do, that one of our best performers has takes a lot of inspiration from defaults. Okay, let's talk about apps later because it's not my area of expertise. So we're going to focus on text messaging studies, but I do think there's a lot of promise for apps. So thank you for all of the great questions. Please keep them coming, and I look forward to diving into those more in a minute. Okay, so our first experiment we ran was trying to nudge people to get flu shots when they already had a doctor's appointment scheduled for a healthy checkup. So these are not patients coming in who think they have COVID or, you know, some other illness that needs to be diagnosed. These are patients who are just having a healthy checkup and are coming in during the 2020-2021 flu season at either Penn Medicine or Geisinger Health. The sample that I'm going to present results to you today is all of the patients who came in during flu season in the fall, so through December 31st. That was sort of our first pre-registered study endpoint. And I should say that everything I'm going to share with you is a pre-registered, part of a pre-registered study. So these are, the analyses will be pre-registered. We had, you know, roughly half and half Penn Medicine and Geisinger patients, a little bit skewed female, pretty, you know, a little older on average. So average age was roughly 52, fairly diverse population, only 70% white. And the rate of flu shot take up in this population in 2019 mapped on pretty well to the national average, 47%. So patients in our study were randomly assigned to one of 20 different experimental conditions. There were 19 treatment groups and one control, and the control group just got the usual standard of care. So like nothing new or out of the ordinary, just the way that they would normally be treated if they weren't in our experiment. And that's our key comparison. And we ended up with an average of 2,365 people per condition in this study, which is pretty well powered. The outcome of interest was whether people got a flu shot at their appointment or in the 3 days leading up to the appointment. And you'll see why I picked the 3 days in just a second. That'll be very clear what that is for. But the key thing was, you know, are we getting them, convincing them to get that flu shot when their doctor offers it to them in the office, or to remember to ask the doctor for it should the doctor forget to offer it to them. But the protocol is supposed to be that the doctor is offering the flu shot during all these appointments. The condition people were assigned to determined which, if any, and the if any is for the control group, text messages nudging vaccination people would receive in the 3 days leading up to their appointment. So the messaging starts 3 days before, and they may get just one message, or they may get a message 3 days before and another day of. That's part of what experimenters could vary. And that's why the 3 days leading up to the appointment are included in our window, because people are getting treatment messages, and that could shape their decisions starting at that moment. So we don't want to like drive people to go get a vaccine at CVS 2 days before their doctor's appointment and not capture that in our outcome variable. So the doctor always asks, have you gotten a flu shot and when? And that gets recorded, and that's how we capture those extra flu shots that might be driven by our treatments. Okay, this was a team effort. So 26 different scientists actually designed the 19 treatments that we ran to test all different hypotheses. So most scientists were designing 2 treatments, one that was sort of like an active treatment where they're trying to test some specific idea, and one that was a control treatment that's trying to tease that apart. So I'm going to pool all of it and just show you all the results, because sometimes the control conditions actually did quite well. But some of the kinds of hypotheses they were interested in were, can humor be used to boost vaccination rates? So one group texted people a joke about, have you heard the one about the flu? Don't spread it around. And they even had, like, I think a dog telling that joke to a cat. Anyway, it was funny. There were pictures involved. One group wanted to know if the option to dedicate your vaccine to a loved one might make it more appealing. Another asked whether learning that a vaccine had been reserved for you might make you more likely to get your shot if you got that text message. So that goes back to this idea of defaults, trying to sort of make it feel like, oh, we're expecting you to get the vaccine, but you can opt out. It's reserved for you. And now, okay, already to the results. The question is, did we increase vaccination rates? And I'm showing you regression adjusted or regression estimated treatment effects here, though if I just plot the raw data, it looks basically exactly the same. This has just a couple of covariates like age and gender and race included, which was our pre-registered analysis strategy, but really it doesn't matter. And what I'm showing you here, there are 19 treatments. I realize it's a lot to read that's on the y-axis. I'll try to dive a little bit into that. So the x-axis is showing you the percentage point increase in flu vaccination from relative to our usual care control. And I'm embarrassed that I didn't label that 0% is 42% is the rate at which people were accepting a vaccine during that 3-day window in the usual care control. So pretty decent number of people in that 3-day window who are saying yes. And then our best performing treatment increased that by almost 5 percentage points. So it's a 4.6 percentage point increase, and that's about 11% increase relative to baseline. So those are like 2 different ways you can think about that number. Notably, you might worry about multiple comparisons here. In fact, you should. And we've done work we have some statisticians on our team who did sort of lots of adjustment work and sort of figuring out in the false discovery rate based on the story Tiberoni. I'm messing up the name. I'm going to call it the ST method, should be about 3%. So we don't have a particularly high false discovery rate here. It's very low. 32% of the treatments significantly outperform the usual care at a P of 0.05. Obviously, like if this were total random chance and uncorrelated, you'd expect that to be about 2.5%. So we're pretty confident there's signal here and not just noise. And of course, you can see directionally everything we tested was better, but some obviously stand out. And those are 95% confidence intervals I'm plotting. So of course they're overlapping, but that doesn't tell you, the key thing is, are they overlapping with this 0? And that's where you can see the 32% that were significant. Okay, so let me tell you a little bit more about what worked rather than just showing you like some stuff worked. And we tested a lot of stuff. So the very best performer, the top performing intervention looked like this. It said a vaccine has been reserved for you and reminded you that twice. So the first message came 72 hours before your appointment. So if you had a 9 a.m. appointment on Friday, you'd get a message at 9 a.m. I guess on Tuesday. That would be 3 days in advance, reminding you that you have this appointment with your doctor. And by the way, you've already received an official reminder about your appointment. So this one's on top of that. And this is the one that says, hey, it's flu season and a flu vaccine is available for you. So protect yourself and your family's health. Okay, hold on 1 second because my 5-year-old, hey Cormac, I need you to sit down here for me, okay? I'm just saying, I'm monitoring all the presentation, so like one seat. Sorry, I guess it was inevitable.
No problem. He could come and say hi.
Do you want to come say hi, buddy?
He said no?
No,
Okay.
hopefully he's not going to burn down the house. I will run away if I hear him playing with fire. Okay, sorry guys. I guess it was too much to hope for, a whole hour of sitting patiently and watching TV in the room with me. I hear little feet. I think we're safe. Okay, so this is the message that was the top performer. The key element, I think, but I'll talk a little bit more about why I think that's key, is that in the second message, 24 hours before the appointment, they let you know that a flu vaccine has been reserved for your appointment with Dr. Smith. So it's been reserved for you, and that seems important. And why do I think that's important? Well, let me show you the second best performer. Most of our treatments, by the way, did not use this reserved language. The second best performer also mentioned that a vaccine had been reserved for you. It also had 2 messages, and it used this sort of reserved for you language. It's been reserved for your appointment with the doctor, and that seems to be important. Again, the third best performer, and the only other message that mentioned the vaccine had been reserved for you was this one. It said, you have an appointment and a shot has been reserved for you to receive your appointment. So that language, top 3 performing messages all had it, and none of the others did. So can I say something a little bit more about that? Well, we did some exploratory attribute analyses. This was led by Linnea Gandhi, who's a wonderful first-year doctoral student on our group. We sort of came up together, actually a big group of us, with different dimensions we could code these messages on, including, does it make you feel positive when you read it? Does it induce positive mood, negative mood? Does it mention that it's a reminder? Is it casual? So some of these messages were more formal, some were more casual. Does it seem like something you'd be surprised to receive from your doctor, like a picture of a cat telling a dog a joke, for instance? And we had very high inter-rater reliability. Then we also coded 12 objective attributes like word count and reading level. Was this a control condition for another study, and so on, including, did it use that language reserved for you? And then she ran a principal components analysis among all the attributes that correlated with intervention success with medium-sized R's. So, not everything got thrown in because there's a lot of stuff, just the things that had medium-sized correlation with our measure of success of an intervention, those beta values from our regression. And there were 2 principal components that were identified by this method. One was, we call it incongruence. So like a high, you'd be very surprised to receive this. It's interactive. It feels casual. So like, this isn't something I expect to get from my doctor. And the other was, does it say reserved for you, and does it use the language of a reminder? And what we see is that those incongruent messages were a very negative predictor of message success, and using the language about reminders, reserved for you, is a very positive predictor of success. So, exploratory, but interesting. It's sort of hard to ignore how strong that reserved for you language jumps out. Okay, so key takeaways from this study, and then I'm going to get to the Walmart data, and then I'm going to take questions, and hopefully my child will not have burned down the house in the meantime. So one is that behavioral science can help nudge vaccine adoption during primary care visits. So we're really encouraged to see this. Seems like it actually can work. These 2 reminder messages were our best performers, and what we're recommending hospital systems consider using messages that look just like these for COVID-19 once the time comes that is, hospital systems. Actually, Penn Medicine is now offering vaccinations to older adults, so they can use these messages in their campaigns to try to encourage people to take that vaccine. And finally, we see this attribute analysis suggesting framing reminders as something that's reserved for you, and making sure those messages are congruent with what you expect to receive from your healthcare provider is wise. But let's see, what happens. Maybe pharmacies are really different. So we ran oh, okay, sorry. And I'm going to stop for a second because I see a question. I actually love the questions in the midst of this, because I know I'm talking a lot. So Andrew, great question. What's the theory behind reserve for you? So let me say that one team, Allison Buttenheim and Gretchen Chapman, actually developed an intervention specifically to test the theory that making it feel like it's a default, that we're expecting you to get this, it's been reserved for you, set aside for you, where there's an expectation and it's personalized, would be really powerful. So that was their hypothesis. And then another team actually just happened to use reserved for you language in a study that had nothing to do with reserved for you. They just thought that would be potent, and those leapt to the top of the pool. And so I think that theory is probably right, that the reserve for you, the sense that we're expecting you to get, we've already set it aside for you, it's got your name on it, that personalization, that sort of default may be important. So yeah, absolutely. You could say it's related to prospect theory, that you're losing out on something that's been set aside for you, and it's an endowment effect kind of thing going on, for sure. Okay, so a mega study with Walmart. This is a much bigger sample size that we're gonna have to work with, and it's a different setting. We're working with Walmart pharmacies where they have 4,700 locations across the US. So it's a much more representative sample than the 2 health systems in the Northeast that we were working with originally. And it's not at your doctor's appointment. Again, it's walking into a pharmacy. So the participants here were Walmart pharmacy customers who had agreed to receive text messages. So it's not, I should say, it's not a fully representative sample. For legal reasons, we could only include people who had agreed to receive text messages and had gotten a flu shot at Walmart in 2019. That's what ensured that we weren't classified as doing sort of direct marketing, which can be problematic. Do you want to say hi, buddy? Come here. Everybody knows you're here, so I might as well show you off. This is my guest.
Hi. So,
okay.
What's your name?
What's your name, buddy?
Cormac.
Cormac. All right,
Great
can you
to
go
meet
back?
you.
Can you go back to sitting for me for just a couple more minutes?
My computer doesn't have any sound. It kept coming back on. And so the music, that's going up, so I can't even turn off.
Okay, I'll help you in a minute. All right, sorry there. Technical difficulties. All right, so the sample includes 735,000 people. They're again skewed a little bit female. They're also older, and unfortunately, we don't know a lot about their race. So this was a big disappointment. We thought this would be a great opportunity to try to figure out what works best for different racial groups, because obviously we're particularly worried about uptake in Black and Hispanic communities, but we don't have a lot of data on race. So we may be able to do some more by matching, looking at zip code data, but right now we're a little bit, I'll just say we have less than we hoped we did. So that's a disappointment. We'll see what we can do with it. The experimental design is very similar to what I just showed you. So patients here were randomly assigned to one of 23 experimental conditions. Here we have 22 treatments and 1 control, but this time we have an order of magnitude more people, so 31,934 people per condition. And the outcome here was the receipt of a flu shot by October 31st of 2021, where we're gonna deliver our treatments starting on September 25th. So roughly a month window. And I have only just looked at some very preliminary data, but as you'd expect, it's really what we're doing is seeing action like right after the text message and then sort of dropping off. So it makes sense, right? Or text message reminder isn't going to drive people in December to come in when they got it in September. So the condition that we assign people to determined which, if any, text messages nudging vaccination people got from Walmart on September 25th and for up to 3 days after. So again, very similar design. That day, that September 25th is your first message, and maybe you include a second message up to 3 days later. 24 scientists, and they're different scientists, although some overlap, designed 22 treatments, and they're mostly different treatments, though again, a little bit of overlap to test different hypotheses. Some of the kinds of things that were tested here were, can describing vaccination as a way to protect family and friends boost uptake? Is that better than describing it as a way to protect yourself? Does learning that there's been an increase in the number of Americans getting flu shots make them more appealing? And we've seen, of course, an increase in COVID-19 interest in the COVID-19 vaccine, so we might be able to use similar messaging there. Would considering all the places you could catch the flu, unpacking that, how many different times you're at risk, make it more likely to receive a shot. So lots of different ideas tested. And let me say, there's one major flaw with this study right now that we're working to address. Right now, we don't feel totally confident that the control condition was handled correctly, so which is a real disappointment. So we may be able to resolve it, but basically when we look at sort of the number of people who are filtered out of the control condition as like bad data, it's an order of magnitude different than the other conditions, whereas the rest look the same. So we're trying to figure out what went wrong there, but I'm going to show you what I'm confident in today, which is a comparison of all the messages to each other. I'm not going to show you the control condition. I will say if we use the control data we have, it looks like the effects were very good and very large, but I'm worried that that's biased. So we'll see. Okay, so this is just comparing the best performing messages against the very worst performer. And what we're seeing here in terms of order of magnitude of strength of treatment, it's very, very consistent with what we saw in our other study. So here, this is the regression estimated percent of patients vaccinated, and the worst performer involved 23.5% of people getting vaccinated at their pharmacy, which makes sense, right? This is, I think, a harder one to get when you're not like walking into the pharmacy for sure in the next 3 days. So it's unlike a doctor's appointment where someone's going to offer it to you. We have to get you to, drive to the pharmacy. Maybe you weren't going to make a visit. So it's about half as many people actually following through in baseline. What you can see is the top performing condition moved the needle on vaccination, pun intended, by 2 percentage points. And actually 73% of our treatments outperformed the worst performing condition at a p-value of 0.05. And again, doing a false discovery rate analysis yields, something like a 5% false discovery rate is what we do expect here. So we think this is probably, certainly at least the very top performer, we can be quite confident is working well. And order of magnitude, the percent increase is almost identical, about a 10% increase, which is what we saw in doctors' offices. And for more consistency, believe it or not, the top performing intervention didn't use the words reserved for you because actually Walmart wouldn't let us use those reserved. Wouldn't let us say reserved because they couldn't guarantee that the flu shot would be in stock, but they were comfortable with us saying it's waiting for you. And it's waiting for you was in one message, and that was our top performer. So incredibly similar psychology, I think, driving what turned out to be the very best way to get people to go and get a flu shot at their Walmart pharmacy. We did the same attribute analysis on this data, again, led by Linnea. 2,400, really big samples, and I'm just getting excited about effects, about magnitude. 2,400 prolific raters classified these on the same 5 subjective dimensions, and we had the same 10 objective attributes. Again, did a principal components analysis. This time we actually identified 5 principal components, but only 2 of them were predictive, and the 2 that were predictive look an awful lot like the 2 that were predictive before and in the same direction. So we had one that looks sort of like a reserved reminder. It says it's waiting for you, or it has reminder language in it. That pops out as a very positive predictor again. And the one negative predictor is one that's about, does it feel like this is a surprising message to get from your pharmacy? You'd be like, what is this about? And interrogative, which is sort of like asking you a series of questions, which you would find unusual. So that was a negative predictor of success. So pretty consistent independent study, but I would say it feels a lot like a replication to me, even though it's in a different context and we didn't test exactly the same things. So I'll say here just sort of more evidence that behavioral science seems like it really can help with nudging vaccine adoption, though I wish we had a control condition. I'm confident that these messages, the spread in their performance tells us a lot in spite of that. 2 reminders, again, encouraging people to get that shot, telling them it was waiting for them, were our top performers. Again, these key factors are very similar. And what I'm really excited to do is start digging into subgroup analyses and to try to figure out what works best for whom with this really big data set. And I wish we had racial makeup, but hopefully we'll be able to do a lot with census data to try to figure that out. And we do at least know gender with fairly high reliability and a few other things about folks. So actually, that is where I'll stop, which is perfect because we were hoping, I think, to have roughly 20 minutes, 15 to 20 for Q&A. So yay for being on time despite slight interruptions. I'm sure Cormac would be happy to take your questions too, if you'd like. And thank you for giving me this opportunity to share our work.
Thank you. Thank you so much, Katy, for a great presentation. And thank you, Cormac. For being probably the best,
mostly playing along,
best part of the conference so far. So so we do have a few questions from our participants. I'll let them ask them. Nora had a couple of questions. Nora.
Thank you so much. I wanted to ask you why you decided for the flu vaccine, as I could imagine this is quite affected by the corona crisis. You could be more motivated to take it than in other years, or less, because you think the masks will protect me quite likely. I think flu activity is quite low. I wouldn't even know from a cost-benefit analysis if it panned out to take the flu shot this year. So why specifically this and not, say, tetanus or something where I could imagine it's not so related to this pandemic this season?
Yeah, that's really interesting. I think, So first of all, there's a really, most Americans are encouraged to get the flu vaccine every year. There are not a lot of vaccines that adults are supposed to get every year. In fact, I don't know of any others. It's also a respiratory illness. And so it has about the same as of September, which is when we launched the study. The rates at which people were saying they get both vaccines were almost exactly the same, roughly 50%. So they wanted a flu vaccine, roughly 50%. So they'd be interested in COVID-19. So it seemed really parallel to us, as did the distribution channels that you could just walk into your pharmacy and get it, which is what we eventually hope will be the case for the COVID-19 vaccine. And, okay, buddy, I'm still presenting. Sorry. So those are the reasons that we picked the flu vaccine for this particular study. I totally agree with you that it is not a perfect parallel, and that's a major limitation of what we did, but waiting until we had wide distribution of a COVID-19 vaccine seemed like that would be worse. So we're hoping to run experiments soon. We're talking to Walmart about running experiments around COVID-19 and try to replicate this in that setting too. The last thing I'll say is, in terms of the cost benefit analysis, I'm with you that it's not clear that it would be beneficial, but back in September, remember, is where we launched these studies. And at that point in time, which is when a lot of the data is getting collected, it wasn't at all clear that we wouldn't have a bad flu season. People were very nervous about 2 pandemics, and there were a lot of fears around, being hospitalized for one and then getting the other and then being sick with both. So, and the rates at which we see people getting vaccines this year for the flu were very similar to past years. So that makes it seem like, even though you might expect it to be an outlier year, and I agree, flu season has been very mild, which is wonderful. I don't think people knew that at the moment when we were running this. But great questions, and of course that's a major limit to how well we can extrapolate.
That's great. And Professor Lowenstein had a question.
Hi, George.
Hi. In the not the very first, but the second study you talked about, was the control no text message, or was it just a very bland text message like it's time for your vaccine?
Yeah, the control was no text message about the vaccine, though the control was usual care, and the usual care involves a text message about your doctor's appointment. And I should say that those usual care doctor's appointment messages went out in all conditions, and then ours were extra text messages about the flu specifically. Does that make sense? So no flu shot mentioned in the usual care.
It makes sense, but to me it seems like the most interesting control would be a very bland text message, because otherwise, how do we know how much?
It's not just a reminder.
Behavioral economics is adding.
I totally agree. So, I mean, that's the beauty, in a sense, of having the 19 different experimental conditions, and we actually can see that sort of the worst performing messages, which were pretty bland, were significantly worse. So, if I'm not going to pull up my graphs again, but I'll say that, like, the bottom of the heap sort of most ineffective strategies we studied were significantly worse, though there were a text message about the flu, than the top performers. So we do see that. And in fact, in Walmart, that's all we have to work with, because we have no control condition. So I think we can say from that it's not just getting any reminder that mentions the flu, because it could be that those were terrible reminders and they were like driving people away from the flu. So there's a limitation of it. But if you look at the text, which we've done, they don't look, I don't think, George, you would be like, gosh, that was obviously a terrible message to have sent and it drove people away. They were all attempting to lift flu vaccination. It's not perfect, but
yeah.
Anyway.
The next one you run, I would really recommend a generic reminder message. Just otherwise,
so that's sort of what the control, all of these are studies where somebody designs a control condition for their own experimental treatment, and many of them were designed that way. So that's basically the experimental decision we made, was like, we have plenty of controls.
Okay.
That's, if that makes sense. And that was one of the things we coded, by the way, in the attribute analysis. Is this somebody's control condition, many of which look like just a bland reminder, and then they're saying like, oh, what if I add to that bland reminder, like dedicate it to your loved one? That was the kind of experiment. So that's why we did it that way. But I will note, some of the bland control conditions did quite well, because it really did seem like they stuck to this script that you're used to getting from your doctor, and they didn't get real cute, which turned out to not be effective. I was really excited about some of these, like we did all these interactive things, we told them jokes, and the jokes, I don't know if you noticed that the joke was the worst performer in the first set that we sent at doctors' offices. So some of the bland stuff was very good.
Just have to target people with refined senses of humor.
Right, I'm sure the joke would have worked really well. It would have worked really well for everyone on this webinar, just not the people in this particular group, or excuse me, in our particular population. But yeah, thanks for your question. I agree, you know, there's different design decisions we could have made.
So Phil Fan and Andrew Ching had questions. Phil, you want to go next?
Thank you, Mario. Katie, good presentation. So, you know, there's been some discussion about this reserved for you, or, you know, here's something with your name on it, and what is it actually activating? And it might be prospect, but I'm not sure. I think that there could be some type of a moral imperative that it might be activating. You know, the idea that there is this thing that is waiting for you, that's reserved for you. If you don't take it, it's wasted. I think it's sort of important to figure out like what exactly is going on in there, and because it sounds very powerful, and there might be a more exquisite intervention if we could precisely figure out what mechanism is there. Anyway.
I agree with you, Phil. I think doing some lab follow-ups will be really valuable to try to understand what exactly is it about that reserve for you, waiting for you language that's driving its effectiveness. And I think Gretchen and Alison Buttenheim, who I mentioned, were the ones who proposed this messaging. I do believe they're planning to do some follow-up work to try to unpack. I think it's really intriguing too. And you know, my guess is it's something combining the endowment effect and personalization. But you're absolutely right. We should figure out what's going on and better understand it.
Katie, just to follow up on that, do you think it's possible that reserved for you makes people worry that this is my chance and I won't get it if I don't take this chance, or that they worry it will get wasted?
I do think that's possible. Yeah, absolutely. I do think that's possible. Yeah. So, and you know, first of all, I'd say like, I'm okay with that if that's the active ingredient driving people to get more vaccinations. And if we did that with COVID-19, it would seem like that would be okay to me too. But it would be very different in terms of, you know, what would we suspect would then be potent if we could go to some other context. We might design some other language that could amp that up even more. Like this, you know, don't let this get wasted, maybe would even make it more effective. And that's the kind of thing we could potentially test. I should say, like, and if anyone on this call has an opportunity to do tests around COVID-19 messaging, I think this seems like an obvious candidate. We'd like to put at the top of a list to get tested and make sure it ports over. And those are the kinds of things we could add. It would be great.
Andrew, did you have a question? If not, I can. Oh.
No, I think, yeah, thank you. I think pretty much the discussion has covered my my take. Yeah, thanks to Katie's really great presentations.
In that case, I'll lend my voice to a member of the audience who've entered some questions in the chat. This is from Raman Kachurka. What do you think? Is it possible that some messages are more efficient to pursue? And this has been addressed to some extent, but do you think that some messages are more efficient to persuade some specific groups than others? In other words, do we need a tailored persuasive message depending on, for example, age, sex, and other factors?
Yeah, we'll see. Actually, you know, let me tell you one thing I know from, we've done very limited heterogeneity analyses so far, in part because we've had the data from Penn Medicine and Geisinger for a month and a half longer than the Walmart data. We literally got the Walmart data last Friday. So we've done very little with Walmart data, and that's where we have a lot more power because it's an order of magnitude larger. But we did do some heterogeneity analyses with Penn Medicine, Geisinger, and there, you know, when we split on sex, when we split on when we split on, is it Penn Medicine or Geisinger, which are generally, by the way, I should say like urban rural is sort of a dimension that goes along with that. When we split on other obvious dimensions, like did you get a flu shot last year? We didn't see differences that were significant in the sort of the beta coefficient estimates we get when we run our pre-registered analysis. The one dimension, and this is really important, on which we do see a difference in an F test comparing all of them is race. And what's really frustrating is that we're wildly underpowered to look at those racial differences. So when we do the regression just on non-white participants, while we see order of magnitude similar effect sizes among the best performers, they're not significant because there's only 10,000 people total across all 19 or across all 20 conditions. So we're really thin slicing. So I was really excited to get the Walmart data and be able to try to dig into race. And of course, then we found out that only 10% of the Walmart patients have known race. So we're going to try to figure out if we can find ways to proxy for race and get into that. But I do think it's encouraging that the other dimensions didn't show heterogeneity, but this race dimension is obviously so important. So, we'll see what we can do there. I also think political polarization is interesting. So Jay Van Bovel has done some interesting research on social distancing and mask wearing and political polarization and how that relates to social distancing and mask wearing kinds of decisions. And we see in polls that it looks like it may relate to vaccination decisions too. So we'll be able to get at that better with zip code.
Thank you. I see that we have time maybe for two more quick questions. Liam Delaney. Liam, would you like to ask your question live? Or I can read it. Okay, so Liam says, I agree with the idea that reserve for you potentially triggers moral norms or worry about waste. One slight worry is that it would generate negative psychological worry for people who have missed it for circumstances outside their control. A particular issue there could, for example, arise if people are self-isolating for some reason. What are your thoughts, Katy, about this?
It's a valid concern. I think, with any of these, but maybe with that in particular, that there's some anxiety that it could provoke. I think that seems like a good thing we could test in the lab or on MTurk. Seems like something we could ask people at least to imagine. Would you be anxious if you'd missed it? I will also reveal my bias, which is I'm sort of okay if we induce a little anxiety on the side as if it moves the needle on vaccination. Maybe that makes me an immoral person. I'm like, if it makes you slightly anxious when you get your COVID-19 vaccine and it saves your life, then I'll get over the fact that I caused you anxiety. But I would like to know what the full range of impacts are. And I think, if we're going to be recommending this, which we are, the more we can learn about it quickly and what's the psychology of it so we can maybe make it more potent, what are the downsides of it so we can try to damp those down would be great. So thank you for asking.
Aditi Sen, she has a question. Aditi.
Hi, Aditi.
Hi, Katy. How are you? Great to see you.
Hanging in there. How are you? Good
From
to see you.
probably nearby in Philly. Just over a few.
Yes, just down the street.
Yeah. I was just wondering what you think about kind of these learnings and sort of effect sizes and translating those over to COVID, given, maybe this is not true, but my sense is that the flu vaccine is pretty well accepted and, people may not get it because of transaction costs or whatever, but in general, people are on board with the flu vaccine, whereas there's so much more uncertainty about COVID, the COVID vaccine and safety and, the 2 shots and all of that. So just sort of generally, how are you thinking about kind of what would translate and what should be tweaked for the COVID situation?
Yeah. It's such a great question. I mean, this is the huge limitation of the work we've done, but I think that, it's why we focused primarily on this, what I'll call the action intention gap, rather than persuasion, rather than saying let me tell you how safe and great the flu shot is, and focusing on that. These messages were really reminder focused, and that gives me more confidence that they may port. I'd be much more worried if we had been trying to alleviate anxieties about the vaccine rather than trying to just remind people and pull them in. But it's still an issue. And so until we do that replication with COVID-19, we will not know for sure. But it still seems to me that this is probably better than just doing our best to guess what would work with a COVID-19 vaccine message. So, you know, it's a limitation, a big one.
I think the reserve for you, you know, it would be interesting to know how well that works and how much of the uncertainty is just because like, I have no idea what's going on. Whereas if you tell me like it's waiting for you, maybe that, you know, does sort of have some kind of like a default, we've decided it's appropriate for you, you know, whoever we is, and now you can get it. So
I'm hopeful that that particular message seems very well suited to porting over, but again, it's just our best guess right now. It's not, until it's tested with COVID-19, it's still just our best guess. Thanks for the question. Thanks to everybody for the great questions and for bearing with me during my BBC Dad moments.
Please,
you guys were great.
Please, thank you so much.
It was lovely to be here, and I'm sorry I've missed some of the other components of this incredible conference. Thank you guys for organizing. It's really an extraordinary group.
Thank you so much, Katie, for an incredible keynote. Thanks everyone for the discussion. We'll take a short break before the next contributed session, and after the next contributed session, we're going to have our second keynote of the day from Professor George Lowenstein. Again, Professor Milkman, thank you, and see you here, everybody, 11:05 a.m. Eastern for the next contributed session. Thanks again.
Okay, thank you everybody. Welcome back to the conference. I think we are about to start the last contributor session of the conference that will be chaired by Professor Liam Delaney. Professor Liam Delaney is a professor of behavioral science and head of the Department of Psychological and Behavioral Science at the LSE. Before joining the LSE, he was professor of economics and led the development of behavioral science centers at the University of Stirling and University College Dublin. Thank you very much for chairing this session, Liam.
Good afternoon, everyone, and thank you to Matteo and to Mario for such an excellent conference and for asking me to chair. The rules I've been given are fairly straightforward, so each speaker will have 15 minutes in total, including any clarifications during their talk, but we will leave the questions until the end of the main questions until the end of the three talks, where we'll have 15 minutes for a general Q&A. So we're going to start with James Allen from the University of Michigan, who's going to talk about accelerating change in norms about social distancing to combat COVID-19 in developing countries. Thank you very much.
Fantastic. Thank you very much and good morning. First, thank you to Mario and Matteo for organizing this fantastic event, and thank you for Liam for chairing this session. Really happy to be a part of it. My name is James Allen. I am a PhD candidate at University of Michigan. And I want to recognize my co-authors, Arlette Mahumane, James Riddle, Tanya Rosenblatt, Dean Young, and Hung Yu, as well as our fantastic field team, research assistants, and funders, without any of whom this project would not be possible. Today, I'm going to be presenting our study, Accelerating Changes in Norms about Social Distancing to Combat COVID-19. This study takes place in Mozambique, a country in southeastern Africa. Specifically, our sample is drawn from 76 communities in central Mozambique that come from 7 different districts, as you can see here on the right. And the first case of COVID-19 in Mozambique was reported on March 22nd of 2020. Now, a few weeks before then, we had advised our field team to start following social distancing, and they reported back to us a fear that people would be offended if they, for example, refused to shake their hand. We had this in mind when we launched a telephone survey in July of 2020 that revealed a large gap between respondents' own support for social distancing and their perception of the social norm. So 98% of people said that they themselves support social distancing, but they only thought that 69% of people in their communities supported social distancing. So we saw an opportunity here to accelerate the emerging social norm, a strategy that Cass Sunstein spoke about in his keynote last Friday. So after that initial pre-baseline survey, this round 1 survey here, we finalized our interventions and uploaded our pre-analysis plan on August 25th. And the very next day began our round 2 survey, which I will refer to as our baseline survey. We implemented our treatments directly following baseline questioning. A day after wrapping up that baseline survey, we started our round 3 survey, which I'm going to refer to as our endline survey. Now, while there's only a day in between the 2 surveys, for any given individual survey, there's a minimum of 3 weeks in terms of their questioning at baseline and endline, and the average was something like 6 weeks. Our final sample is 2,117 households. As I said before, these come from 76 communities across 7 districts in central Mozambique. We recruited them over the phone from a list of study participants from an ongoing RCT of a community level health program of which myself and my co-authors are a part of. Now, the response rate on this COVID-19 telephone survey between baseline and endline was 95.1%. I have some sample descriptive statistics here, so you kind of get a sense of who we are surveying. Almost everyone had heard of COVID-19. Exactly half of the respondents were female. Average age was 37. And these respondents came from households that had just over 6 household members. Almost every household had at least one individual under the age of 18, and just over a third of them had older adults age 60 and up. So what are the interventions we're going to do? The first we're calling the social norm correction. So as I said before our baseline, we asked individuals if they themselves supported social distancing. We used that to calculate the fraction of households in each community who support social distancing. And this was 9 out of 10 or 10 out of 10 households in all of the 76 communities. Then at baseline, we asked for every 10 households in your community, how many support social distancing? And in this treatment, if you underestimated the true share, we then told you the true higher share of support. And this was the case for almost half of the treatment group. And if you correctly estimated the true share then of community support, we then told you that your guess was correct. And this was true for about 43% of the treatment group. Now, 7% of the treatment group actually overestimated community support. And in that case, we didn't reveal that information. We just didn't tell you anything. Our second intervention is our leader endorsement. So before our baseline survey, we identified community leaders. These are both local leaders serving in some official capacity like village chief, as well as opinion leaders that were nominated by their community in a prior round of survey work. Now, we called these individuals to get their permission to tell others in their community that they, quote, support social distancing, are practicing social distancing, and encourage others to do the same. And in this treatment, we simply informed respondents that their community leaders, and we mentioned them by name, supported social distancing. So how do you think these social distancing interventions would affect social distancing? This was the exact question that we asked 71 social scientists in an expert prediction survey. And while their predictions varied quite a bit, the average expert predicted that both interventions would increase social distancing by about 5 percentage points or over 5 percentage points. Now, while our experts predict positive effects overall, theoretically it could go other ways. I think we here would hope and expect a positive effect given the literature on people conforming to the social norm, but there could be a negative effect. There could be a free rider problem, since learning that other people are social distancing more actually might reduce your private benefit of social distancing. Or there could be no effect if neither intervention succeeded in shifting the perceived social norm. So we're going to test this using interventions in a randomized controlled trial design, and we're going to estimate the intent to treat effect. A randomization occurred at the respondent level, and there's only one respondent per household. And randomization was stratified by our 76 communities. Now, our sample, our retention was balanced across all treatment arms, and you can see in this table that roughly 40% of the sample was assigned to the control group, and roughly 30% of the sample was assigned to either the social norm correction intervention or the leader endorsement intervention. Now, what outcome are we going to use to test the efficacy of these interventions? Rather than rely on self-reports, we develop a more objective measure of social distancing, one that can still be constructed using phone survey data in a context in which study participants likely know each other. So what we did is study participants themselves were asked about their social interactions with 10 other study participants in their community. These 10 others were determined if they were a social network contact from some prior social network data that we had, or simply by geographic proximity, your nearest neighbor. And we did this both at baseline and at endline. Further, community leaders were interviewed before the intervention and also after the intervention. And during this, they were asked about their social interactions with all study participants from their community. Some of the key questions we asked were, have you seen anyone from that household in the last 14 days? And if the answer was yes, we then asked, did they come closer than 1.5 meters? Did they try to shake your hand? Did they appear to be observing the government's recommendations on social distancing? So using these others reports, we're able to construct a social distancing indicator that is a dummy if you're practicing social distancing according to your self-report and according to others reports. So your social distancing according to your self-report, if you answer yes to the question, have you been observing the government's recommendations on social distancing? That's a simple singular question. And also, if you are doing more social distancing behaviors out of a possible 8 than the sample median number. Your social distancing according to others, if all the reports from other study participants and community leaders found that respondents did not come closer than 1.5 meters, did not try to shake hands, and did appear to be observing the government's recommendations on social distancing, or the respondents were not known or had not been seen in the last 14 days. So simply not being known by anyone was a rarity. Each respondent household was known by an average of 1 community leader and 3 neighboring survey respondents. Before I jump into the experimental results, I want to share some interesting summary statistics that compare support for social distancing versus our measures of behavior. At baseline, you can see that 99% of people said that they supported social distancing, and they thought that 80% of the households in their communities supported social distancing as well. That perceived social norm went up a bit from our pre-baseline survey, but there's still a gap between that perceived social norm at 80% and actual support at 99%. Now let's compare this to behavior. According to our social distancing indicator, only 8% of our sample was actually practicing social distancing. And this is not driven by any specific subcomponent. You can see that 36% were social distancing according to their self-reports, and 22% were social distancing according to others' reports. Now, our outcome is complex and incorporates a lot of different types of information. However, a lot of studies that have been published that evaluate messaging strategies to promote social distancing often use as their outcome self-reported social distancing, often from a singular question. And we have a question like that. We ask, yes or no, did you follow the government's recommendations regarding social distancing? And you can see here that 95% of people said yes, right? But then when we add additional types of information, we get a more nuanced picture and maybe better tease out who's actually practicing social distancing. Something that's really easy you can do is ask about social distancing behaviors and create an index and simply compare that to the sample. So that's something that we do here. Now let's look at the experimental results, the effect of these different interventions on the perceived social norm. We'll consider this kind of our first stage regression here, our first stage analysis here. Our outcome in this figure is the perceived share of households in your community that you think support social distancing. We're looking at sample means for our 3 treatment interventions, both at baseline and at endline. And what you probably get a sense of from looking at this figure is that there's not much change. The interventions don't seem to shift the perceived social norm that much. This 1 asterisk right here denotes that when we analyze this using our pre-specified regression framework, we see that there is a small positive treatment effect significant at the 90% confidence level from the social norm correction intervention.
5 minutes remaining, James.
Fantastic, thank you so much. So what then is the effect on behavior? In this figure, we're looking at that social distancing indicator, that indicator of behavior, and again, looking at the sample means across the interventions at baseline and endline. And you can see that there's virtually, literally no change whatsoever in behavior as a result of the leader endorsement over here. And there maybe it looks like there might be a small treatment effect increasing behavior by maybe 1.4 percentage points from the social norm correction. But it turns out that when we analyze this using a regression, our pre-specified regression framework, we get a positive but insignificant coefficient. So we cannot rule out that the average treatment effect of either intervention is statistically different than 0. However, earlier on, I said that, these interventions we would hope have a positive effect, but they also could have a negative effect. And perhaps whether it's a positive or negative effect depends on the context. Well, it turns out that we estimate differential treatment effects based on the number of COVID-19 cases in a respondent's locality. So I want to show you that now. So in this figure, each triangle and whiskers represents the district level treatment effect of a social norm correction intervention on our social distancing behavioral indicator. And on the x-axis, we have the district level cumulative COVID-19 cases at the start of the N-line survey. Now, in the district with the fewest COVID-19 cases, only 3 down here, we actually estimate a negative treatment effect that's significant at the 90% confidence level. Now, you may not be able to see that, but you can probably see that all of the triangles down here are, in this lower left corner have a negative coefficient. This seems to attenuate as COVID-19 cases increase. And then here in the district with the most COVID-19 cases by an order of magnitude, we estimate a significant positive treatment effect, suggesting that the social norm correction increases social distancing by 9.3 percentage points, a 75% increase from the control group in that district. And so this is really important. It turns out that the social norm correction can be very effective in certain contexts, but can actually be harmful in other contexts. So we are currently trying to understand and pinpoint the mechanisms driving these heterogeneous results. And so one likely candidate seems to be perceived risk. So the outcome in this regression is the expected share of households in your community that you think will get sick from COVID-19. We added this question a little later on in the end line, so it was only available for 4 districts, but you can see the pattern is the same as the one we saw on the previous slide. In the districts with fewer COVID-19 cases, the social norm correction actually has a negative treatment effect, leading you to reduce your perceived risk. Getting the social norm correction made you say that you thought fewer people in your community were likely to get sick from COVID-19. But this effect seems to attenuate as COVID-19 cases increase. And again, in the district with the most COVID-19 cases, we actually see a positive treatment effect. The social norm correction led you to increase your perceived risk and think that more people in your community were likely to get sick from COVID-19. And so this is currently where we're at with the research and trying to kind of understand the mechanism here. And we look forward to getting your feedback on this part as well. So overall, we contribute we run a large scale randomized controlled trial and contribute experimental results that test the effect of social norm corrections and opinion leader endorsements on social distancing perceived norms and behavior. And we hope that this adds to the literature on effective messaging to promote social distancing, but also adds to the literatures on norm-based interventions, as well as opinion leaders and the roles that they can play in promoting good health behaviors. Thank you so much for your time. We're looking forward to your questions and your feedback. I want to point out that our project website is located on the bottom slide here. You can go check that out for more information on our project. I also have our email down here, my email, and feel free to email me questions if you don't get a chance to ask in the Q&A. Thank you very much.
Excellent, and bang on time, well done. Just Glenn has one brief clarification on confidence. Do you have confidence intervals for the effects?
Yes, so the whiskers in these figures here represent the 95% confidence intervals.
And I'll let Glenn follow up in the general Q&A. So we'll have more time for questions at the end. But thank you very much again for that, James. It was excellent. So our next speaker is Professor Sarah Lenardi from the University of Pittsburgh, who's going to speak about to mask or not to mask on the salience of risk and the efficacy of government messaging. And I'll give you a 5-minute warning towards the end, Sarah. Thank you.
Sounds great. Thank you, Liam. Let me just share my screen. Okay. Think everybody see my screen. Okay. Thank you, Mario and Matteo, for putting together this excellent conference. So this is a paper on the early days of COVID-19 when masking was not yet political. And my co-authors are Lucy Gillespie, a PhD student at GISPIA, and Daniel Jones, who is also associate professor at GISPIA, and we're all from the University of Pittsburgh. Okay. So our original question here started with the problem of there is a lot of messages from the government. So for example, outside of COVID-19, you know, Lucy was studying a lot of disaster management, and she was looking at the effect of warnings from the government, hurricanes and fires. There was a lot of fires in California at that time. There's a lot of messages from the government about healthy habits, and including now wearing a mask. So the question is, does government messaging change behavior? So the literature has both sides. So there's some that says government messages do positively impact behavior, such as in reducing smoking, quit attempts, in flood evacuation compliance, in reducing sugar sweetener beverage purchases. But there's also some that says the government messages has no impact on behavior. So this include alcohol warnings, dietary supplements, gambling behavior, or wildfire evacuation, which was what Lucy was studying. So what the framework that we're trying to use to study the differences between messages that work and doesn't is on salience. So what we mean with salience here is the top of mind awareness of the risk of something that you already know. So it's not like, you don't know something, but it's just you're inattentive and not thinking about it. And so, for example, this paper by Haslett and Mildenberger find that people in California who live like 5 miles away from a fire is less likely, the people that live within the 5 miles were more likely to vote for climate-related policy, but the people that was 5 miles outside were not. So everyone clearly knows that something's going on, but their willingness to behave is different. And there's also the Chetty paper on taxation, where people know of the taxes, but when it's on the packaging itself, then they become more likely to behave differently because of it. So when we look at government messages, it's often conflated between salience and messages, and that's one of the things that we want to look at here. In particular, the theoretical models of salience suggest that there would be a diminishing sensitivity to increased salience, right? So when you're bombarded with a lot of different messages, at some point, increased messages doesn't really change your behavior anymore. Okay, so this is what this paper is going to ask, whether or not low and high salience affect the effectiveness of messages. And here we are in a situation where there's positive and negative messages that we can contrast that was happening at very, very close amount of time in April 2020 during the pandemic. In particular, before April 3rd, 2020, the CDC recommends healthy individuals to not wear masks. And then on April 3rd, they recommended that they do wear masks. So will the government messages, wear or not wear masks, changes citizens' willingness to value masks, to buy them, to own them? Okay. I can point to many other messages that at that time that seemed conflicting or were given at successive, quick successive intervals, but this is just one of them. Okay, so for our experimental treatment, we ran a survey at Prolific, which is like an online platform like Amazon MTurk. We recruited 512 people and ran a preliminary survey, and then they were randomized into 2 salience groups. One was shown the state statistics, and I'll go through this later and show you the screenshots, and the other one wasn't. And then they were shown randomized messaging treatments, which is control, no messages, pro-mask, the CDC message on wearing masks, anti-mask, positive forecast, and a negative forecast. And this is on death. And then we had them do a choice task, which is then they allot tickets, lottery tickets, to bid on either a face mask or a Starbucks gift card. And then in the end, they do an exit survey where we show them COVID-specific questions, and then we debrief them with what CDC currently recommended they do. All right, so the baseline survey, we recruited people from all 6 regions of the US with moderate level of COVID-19 occurrence. And then we used the 538 state similarity score index to get pairs of states from each of the 6 regions in the United States. So these are the sample size from our sampling. And then we had them do a survey of general things like overall health and their just basic demographics behavior before we then allocate them to the state stats and the no state stats treatment. So all of this is very simple. It's like things that you see on your newspaper every day and like on the radio and on TV, which is, it's just a statement 4/13/2020, which is when this was happening. There's been 101 deaths at the state of Tennessee, for example, right? A number that seemed really big just a year ago and seemed very, very small now. The number of cases confirmed in your state has reached some number with some number of tests performed, right? So this is the thing that they're shown for the state stats treatment, and the people that were not in the state stats treatment, which is not shown anything. Now everybody is now randomized into 5 messaging treatments. So let me show you that. So the first one, just show you the CDC pre-April 3rd statement, which is if you are not sick. So we basically take the statement from the CDC website. If you're not sick, you do not need to wear a face mask unless you're caring for someone who is sick. Now the CDC statement on April 3rd says the CDC recommends that citizens wear a cloth face covering or a face mask in public setting. And then for the other 2 positive and negative forecasts, we used the Institute for Health Metrics forecast that was used by the White House. And then what their forecast was that by August 2020, the United States will have 60,000 coronavirus deaths. And this is framed as 20,000 fewer deaths than earlier forecasting models predicted, or the growth rate of confirmed cases and deaths has been the highest in the world, right? So the positive or a negative way of framing the same thing. Okay, so that was our messaging treatments. After people were exposed to the messaging treatment, we had them choose between a bid on a face mask or a Starbucks gift card. And so the Starbucks gift card, choice 1, was valued at $75. It's a pretty big gift card. And then choice 2 was to receive an N99 face mask. And this N99 face mask in April 2020 was completely unavailable. This is a reusable face mask that can be used up to 3 months, and you cannot find it in Amazon anymore. So they put the number of tickets for the Starbucks gift card and the N99 face mask between 0 and 100. Okay, after that, we had them do an exit survey, which includes COVID-specific questions now and manipulation checks. So for example, we asked them whether their state is doing well or badly. We asked them about the importance of masking, and then we debriefed them that CDC actually do want them to be wearing a mask. All right, so let me go into the results. So just some basic summary statistics. We looked at here 493 are the numbers of people who answered the lottery questions properly. So they had 100 total in the mask, in the tickets that were allocated to the mask and to Starbucks. We have 57% female, 27% self-identify as living in urban neighborhoods, 17% Republican or Libertarian, 63% between 18 and 35, and 29% between 35 and 55. So we weren't able to reach a lot of the senior population. Most of them regarded their health as good. So be in a scale of 1 to 10, they regard their health score at 7.6. The demographics are balanced across treatments. So this is just showing you that it's all it's all balanced across all our messaging treatments. We have a so now just looking at the tickets that people bid for masks. 57% of people have put in a positive number of tickets for the mask. So if you look at the distribution, it's highly bimodal with a lot of zeros. And then 57% that put at least 1 ticket into the mask with a bump at putting all their tickets into the mask.
That's 5 minutes remaining.
Thank you. Okay. So one question that you might have is, does the state stats treatment increase salience of COVID-19 risk? So one possibility is that people don't actually know that their state had a high or low number of deaths, and what the treatment does is inform them. The other possibility is they do know what these numbers are, or roughly what these numbers are around, but the treatment raised their concerns about how bad things are happening, regardless of the actual level of death in the state. So we're going to test for this. So what we did here is, let me just say that the state stats, people in the state stats treatment are 7% more likely to say that things in their state is going badly with regards to COVID-19. And we interacted the state stats treatment with the number of actual deaths that is in that state. If it is an informational effect where people were not aware of the death in their states, you would see that the treatment would have more of an effect on states that have high death. But what we found was that the interaction wasn't positive and significant when we looked at high death states versus low death states, which indicated that regardless of the actual death in the states, showing them the state information increases their awareness of the risk of COVID. And we find the same results when we change it into risk to self or other variables that we have. So what is the effect of the government messages? So here you could see the full sample. The gray bar are the no message treatment. So you see that 60% of people are putting in some tickets into the mask. The blue bar here is the anti-mask or do not wear a mask treatment. So a little bit under 50% of people are willing to put in some tickets towards bidding for the mask. The dark blue bar is the pro-mask treatment. And then the difference between the light blue bar and the dark blue bar is significant. So this is the effect of the anti-mask, the pre-April 3rd versus post-April 3rd messages. The positive and the negative forecast, which is the pink and the dark pink, does not have an effect. So again, this is putting the IMHE forecast in a positive or negative light. So if we look further at this results, where we see in the poll results, action-oriented messages change behavior, we see that all the results were coming from the people that were not given state-level information at the same time. So the no state stats treatment only got the government messages, while the state stats treatment got both the government messages and the state information on death and tests and all that other stuff, right? So what we pull from this is action-oriented messages seem to change behavior when it's decoupled from the state information. So we test this with regressions, interacting the messages and the salience. And what we found was very similar to what I just showed you. So in the full sample, the differences between the anti-mask message and the pro-mask message was that people were 12.4% more likely to want to bid for the mask. This was all coming from the people that were not shown the state stats. They were 23% more likely to bid for the mask. And then the negative or positive forecast did not have an effect. When we take out Republicans and Libertarians, which some recent research have shown to be difficult to move, what we see here is the effect becomes even stronger, with almost 17% of people's behavior more willing to bid for a mask in the pro-mask treatment. And when decoupled from state messages, it's like 34%. So overall, what we found was that action-oriented directive from the government increases the fraction of citizens that value the PPE positively. And the directive has less of an effect when the risk was already salient, in the sense that they were shown the state information. So it seemed that decoupling the directive from too much information here has an effect. So overall, what we did, we ran a survey experiment with 512 people from the 12 states that only had a moderate amount of COVID-19 risk. And we found that they were much more willing to bid for the PPE with the simple action-oriented messages. Thank you very much.
That's terrific. Thank you very much. And again, bang on time. So we move on to the third talk before the general Q&A. So welcome to Dr. Sebastian Schneider from the Max Planck Institute for Research on Collective Goods, who will speak on, you can see the title there actually, so I won't read it out, it's on the longer side. So welcome Sebastian, and I'll give you again a 5-minute warning towards the end.
Thank you. Yeah, thanks for having me. 1 second, I arrange my slides here. Okay. Yeah, so hello, welcome to this last presentation before the next keynote. I'm very happy to be here to present, and thanks to Mario and Matteo for organizing this conference, and of course everyone else involved. Yeah, my name is Sebastian Schneider. I'm presenting a project on a randomized control trial to evaluate the effectiveness of measures to contain COVID-19 in rural Bangladesh, which is joint work with Jamal Chowdhury, Anna Schildberg-Hörisch, and Matthias Sutter. What we did in the study was we did an RCT to compare the effectiveness of an information campaign with a monetary treatment. And we conducted the experiment via phone with more than 3,000 households from 150 villages in 4 rural districts. We had 3 treatment groups. The first is a control group. We had control households in treated and untreated villages. And then we had a treatment group, which is info only, where we basically conducted an information campaign. And in that information campaign, we illustrate the effects of an exponential spread of COVID-19 in the village, giving an example saying that, well, if you infect 10 persons and they infect 10 others, and they in turn infect 10 others, then already the whole village is infected. So it really matters. And then we basically summarize the governmental campaign by informing them about the 3 most important social distancing and hygiene measures, informing about the 3 most common symptoms and 3 measures to take in case the respondent or someone else from the household shows those measures. We also gave a reminder a week later, so we called them again and asked, hey, do you still remember? There were 3 things, those are the things in case they didn't remember. And also importantly, after the phone call, we summarized all those points and sent them a text message to summarize everything. The next treatment is the Info Plus Money treatment, which consisted of the information campaign and an unconditional cash transfer of 2 to 3 days worth of agricultural wage in that area. And the motivation behind it was to well, A, signal that it's really important, and B, also it was thought as a support or a compensation for participants to stay at home and stick to the social distancing rules. Because in that context, staying at home means foregoing money because they can't go out and sell their stuff on the street or work on their field. The money was paid unconditional, so there was no enforcement, and we clearly stated that. We after the intervention, we conducted 2 household surveys, one 2 weeks after the intervention and another about 2.5 months later to find out about the effects of our intervention. And importantly, also we did 3 village questionnaires, one of them before the intervention, to learn about the situation in the villages. Now let me give you some background about the setting in Bangladesh with respect to COVID. So COVID reached Bangladesh relatively late in 2020, and around March, beginning of March, the first cases were confirmed, and mid-March, the first death cases due to Corona or COVID were reported. And the growth rates stay more or less linear for a relatively long time compared to many other countries. So it hit Bangladesh relatively late. And given the population, it's about 170 million. This is like double the size of Germany. The numbers are relatively low. So here we see about 20,000 is the weekly increase in infected cases. And some weeks ago, we had it in Germany on a daily basis. So that's really low. But however, another feature is that the second wave here is also not hitting Bangladesh that hard, also compared to many other countries. This is a stark difference. So, however, those numbers probably only reflect or mainly reflect the capital region about Dhaka, because testing was possible or free of charge in government facilities, but there were only 2 laboratories for a long time in Dhaka that could actually test. And then there was introduction of a fee for testing around here, which you can see in the numbers. Okay, so Bangladesh reacted to the numbers relatively early and only 8 days after the first death imposed a lockdown. People have been asked to practice social distancing and stay at home. However, that did not really work out. So this is in the middle of the lockdown, April 18th. About 100 people came together to attend the funeral of a famous Islamic scholar. So the lockdown was extended several times, ultimately ceasing on May 30. And another feature that is worth stating is that around 10 million Bangladeshis work overseas, especially across the Middle East. So they were first to leave many of those countries. So that means that a lot of migration has happened with the onset of COVID-19. Now, with respect to the study design, so this is the same graph as before, but just for the first wave, we conducted our first village questionnaire around here to learn about the situation, and then started our intervention right here, so where numbers were still really low. And then still during the time of the lockdown, here in those 2 weeks, we conducted our first household survey, and about here, where the numbers then decreased, already conducted the second household survey. And yeah, so with respect to treatment assignment, as I said before, there was a lot of migration happening, so we had to take that into account. What we did was a two-step treatment assignment. So we first allocated 90 villages to 2 treatment groups, so 45 villages each, and 60 villages to the control group. We did so using the MIN-MSE method that I developed together with my co-author Martin Schlatter. And the idea is basically to bring matching to the group level. So to have the groups balanced with respect to the covert, the entire covert distribution on the group level. And the coverts that we used or that we accounted for are from the village survey. So we asked for mobility, the number of people that returned to the village from abroad and bigger cities in the last 2 weeks and also since February. We asked about restrictions on social gatherings, so whether Friday prayer has been restricted to fewer people and to how many, whether tea stalls are still open and so on, and for big events, and also the number of people that that show COVID-19 symptoms, have been diagnosed, being in home quarantine. The second step of treatment assignment was then on the village level. They used a matching algorithm to group households into pairs of neighbors, so using the physical distance. So we had geo-information on all those households before. And so, for example, this is a neighboring pair of households, and then importantly, only one was assigned to treatment and the other was assigned to the control group. So with that design, we can study spillover effects, but we also use it for another feature I come to talk about in a second. So to find out about the effect of our intervention, as I said before, we conducted a household survey, and I'm going to talk about the scales a little bit more when I talk about the results, but just to give you a brief overview, we have registered 3 outcomes: knowledge and attitudes, a behavior scale that basically included preventative measures and also social distancing measures, a health scale where we basically looked at symptoms, being diagnosed, home quarantine, and whether someone in the household deceased. Importantly, all scales are standardized with respect to the control group, and higher values are more favorable. So let's look at the first result. This is the knowledge and attitude scale. And here we see treatment effects 2 weeks after the intervention and 3 weeks after the intervention. Yeah? And the treatment effects are expressed in standard deviations of the control group. The control group here is omitted because it's standardized to 0. And
5 minutes remaining, Sebastian.
Thank you. So for the info treatment, we see that the treatment effect is 0.4. So knowledge and attitudes are increased. We see that it's highly significant. Well, we see that it's significant with by the confidence intervals. For both treatments, also pooled treatment effect is positive, and 3 months later, only for the info plus money treatment, it's still significant. The significant effects are also robust to controlling for the situation in the village before, and in fact, that reduces the gap here. And we can see here that the effect is basically fading out, but this is not because everybody forgets the most important things or whatever. This is rather because the control group catches up. So what is in that scale? We can see that we asked people, how can you make a difference in fighting COVID-19, and gave a list of options, for example, eating garlic or staying at home, and then just counted the number of correct answers. We also asked whether, or we also accounted whether people think that everybody in the society can make a difference, and we asked on a 1 to 5 scale whether they agree that they themselves personally can make a difference. And we see that here the control group just catches up. So this is how we can explain that. Now let's have a look at the behavior scale. The behavior scale basically measures the adherence to prevention measures and physical distancing measures. Here with neighbor interaction and without neighbor interaction in the upper panel. And the interesting feature is we did it relatively similar to what Alan did. So we also asked neighbors about their neighbors, and that we included here. So what we see is a relatively similar picture compared to the knowledge scale. We see that in the info plus money treatment, the effect is stronger compared to the info treatment alone. Here the coefficient is still positive, although not significant anymore. And what we can see here also is that the effect fades out. But here, contrary to the knowledge scale, it's really also that people do less or stick to the social distancing measures in a lesser degree. The groups, one important thing is that we asked about prevention in the week before. So like on how many days people sneezed more often into their elbow than they did before the pandemic. And in that aspect, the groups are relatively similar. So info treatment and info plus money treatment. But when it comes to really doing or adhering to social distancing or physical distancing, then the money makes the difference, so it seems. However, another thing to note is that here 3 months after, when the effect fades out, the numbers are already increasing. So it might not be that bad what we observe here. Then finally, looking at the health scale, here we see a different picture. We see better health for the info treatment compared to the info plus money treatment. We see significant treatment effects for the info treatment, info plus money, and also that pooled. And still 3 months later, we see a significant treatment effect for the info treatment. The picture is more or less the same, whether we look at 2 weeks or whether we look at 3 months, whether we look at a respondent or whether we look at the whole household and include the information from the household. And what we basically included in that scale was typical symptoms, a combination of high-risk symptoms, being diagnosed with COVID-19, being in home quarantine, the average of all this for the household, in case the household was included for those 2 here, and if any household member deceased. Now let's look at the probably most objective outcome. This is the share of households that reported deceased household members since the outbreak of the pandemic. And here we see that in control households, this share amounts to 1.6%, whereas in the info treatment among the treated households, this is less than 0.5, and in the info plus money treatments, it's still around 1. So the combined, so the pooled treatment is here at 0.8, and this is still significant. And it's robust to controlling for the situation in the village before the intervention, to personality traits, the economic preferences, district fixed effects, and even using randomization inference. So this is really robust. We have many other results on spillover effects. Indeed, spillover effects is exactly the same magnitude than the main effect. We have demographics, economic preferences, high order risk preferences, common risk preferences, time preference, social preferences, where the latter seem to matter. We have information on personality traits, trust, big five, self-control, and so on. But today, I'm just gonna summarize what I've talked about. So both treatments improve knowledge and create the attitude of being decisive in fighting COVID-19, which then translates into improved behavior and subsequently improved health. And this, even after the lockdown was already in place, long in place, and we basically just repeated the information that the governmental campaign included. So that means that they might not really be successful in communicating. And the share of households reporting a deceased household member decreased from 1.6 among the households in control villages to 0.8 among treated households in treatment villages. And the implication is that would the info treatment scale to the national level, around 5.5 thousand of the more than 8,000 deaths could have been avoided. So thank you very much for your attention. Looking forward to the questions.
Great, thank you very much, Sebastian. Feel free to put into the Q&A or the chat any questions that you have for the participants. I just firstly wanted to, for Sarah, this issue about the mask filters, could you, I know there was a few questions in the chat, could you just address that, please?
Oh, the mask that we use did not have a filter.
So hopefully, yeah, and then Glenn, I mean, feel free to unmute or just on the question about the confidence intervals. So for James's talk, maybe.
I was looking at the actual confidence intervals. Of course, you've got them there. They're the bars, but then you seem to be making statements about the trends based on point estimates, ignoring the fact that virtually all of the earlier ones were statistically insignificant. I just kind of missed. It sounded like you sort of wanted to tell a story about a trend. I get that. People want to sell a story and get the paper published, but all of them except the last one, the one on the right, were statistically insignificant. So what am I missing?
Yeah, right. Thank you very much for your question, Glenn. It's a great one. For the sake of time and kind of out of respect for the practitioners and the audience, I think we tried to kind of paint the picture using figures, and I tried to describe the trend that we do find when we run regression results. If I can quickly share my screen, I can show you some of the regressions that support the story that I was kind of telling. So here we have this indicator of social distancing. Here we have our treatments, and then we interact those with the district COVID-19 cases, as I described in the study. And you can see here that the social norm correction treatment, we do get a significant negative effect. While any single district level effect on that left-hand side, the confidence intervals did cross zero. I see what you're saying there. When kind of pooled together, we get this negative effect, and then you see this positive interaction that when you multiply that by the number of COVID cases in that one district, you actually get that very strong positive effect. And then this is over here, the regression on that risk outcome that we were looking at, and you see the same pattern there. So I was describing it.
Sure. Just a quick question. These are ordinate least squares regressions on things that are not between minus infinity and plus infinity?
Yes, I think there's still a debate about people's confidence in running ordinary least squares on bounded outcomes.
No, not at GSU. There's no debate. Sorry, I mean, but that I just wanted to know what you did. You're running OLS on these on dummies, so that's fine. I got it. Okay, thanks. Okay,
but I guess to encourage others, I think that many econometricians are okay with running OLS. Though, to be fair, I guess if we were pursuing this further, we could run different specifications to kind of double check that it holds and you run a logit or something like that. Sure. I should add, though, that this is more of a speculative analysis. These were not pre-specified, unlike the main regressions that I described and that we have as well. And so they should be taken with a grain of salt, and we're currently exploring and trying to refine them as well.
Yeah, I don't take frustration seriously either, but that's another story.
Great. I mean, Glenn, I think we're at the point of we will take that one off, but it was points well taken. Sebastian, there's a number of questions that hopefully you can see them in the chat. I think people were very interested just in the logistics of the study. So in the Q&A, there's a question about how did you get the sampling frame? What is the sampling frame effectively with the phone numbers? So maybe do you want to address that one first?
Yeah. We were working with the sample for years. Well, not me, but my co-authors. So we already had a sample established there, and that makes it also possible to get all the information, the preferences, personality traits, and so on. And in that case, also the telephone numbers and also the geographic information. It was all available before we started the study. So yeah, basically we were working with them before. That's it.
And your behavior, the behaviors in your study, they're all self-reported, right? That's from Neela Saldana.
I was about to typing my answer here, but I can't leave that now. It was self-reported with respect to prevention and also social distancing in the week before the interview and also on the day before the interview. But then we also asked about interaction with the neighbors in the last 7 days. And importantly, that we asked also to the neighbors. So we had that the treatment assignment where only one of the neighbors were in treatment and the other in the control. But we knew that they were living next to each other. So we asked them, in this and that situation, when did you last see your neighbor? Or how often do you usually see your neighbor at 12 or whatever? And then we asked, so in the last 2 weeks or in the last 7 days, I think, how often did you meet? And then we take the difference, and that's the reduction. And this we asked individuals themselves. So this is self-reported, but also reported from the neighbors. So it's both.
I can see that Armando Meier is there. I mean, you were asking about the what they did with the money. Do you want to unmute? Maybe do you want to elaborate on the question, or I'm happy just to pose it?
Yeah, no, I think it's. I would just be curious to see it because it might, you know, depending on what people, how it changes people's behavior. It might be that they take more risks when you give them money because, you know, depending on what they spend it for, they might encounter more risks than they would otherwise. So this is why I was curious about it.
Yeah, no, we haven't asked that yet, but as we keep working with the sample pool, we're gonna include it in one of the next rounds. But we haven't heard so far.
A question, Sebastian, from Brit Spiru, and this sort of a two-part question, so I'll let you figure out how you want to answer it. But why do you think the monetary incentive has less treatment effect on deaths? And is it something like, I think they're referring to the the perverse incentive study in crashes? So is finance the right frame for something like this?
Well, it seems it might not be the case actually from what we observe, right? So the info treatment is way better. It might be that there seems to be some fade out effect, right? So that people start adhering to those measures once they think the money that we paid for that is gone. Might be. It might also be that, you know, in addition to giving the information, the money was like a second thing. So it distracted a little bit from the information. So if I imagine that after us calling them, the info treatment just sit together and talked about us calling them, whereas the others in the household probably also talked about the money. And also when spreading the news around the village, so we see that there is a spillover with respect to knowledge, which can also happen like with a distance. So usually in rural settings, this is not too much of a concern. But so it might be that villages just tell the others way more about the info that was spread if they do not receive money, because otherwise the money will be the topic of interest. But those are guesses. We don't really know what happened. Yeah. And especially it's interesting because self-reported behavior seems to be better for them, and also knowledge seems to be better for those that were paid money. But it might also be that the behavior scale is a little bit distorted in the sense that they report more favorably.
So we still have approximately 5 minutes if anybody would like to type any other questions into the chat.
I just want to make a comment on Sebastian's point just now.
Of course.
So that just struck me as like similar to what we're finding with like things having to be very, very simple in this setting and like just very like single dimensional. How do you feel about that?
Yeah, well, this was how we designed everything. I mean, we can't, in the end, we can't toss out which feature exactly was it that made the difference, which can talk about money versus no money. But when designing all the intervention, we took care to really make it very simple, because we did it over the phone. So it had to be really, really simple. And then we focused on just giving 3 or like for everything, a list of 3. So at the end of the day, when you try to remember it, then you can probably remember that it was 3 things. So I would from the results that we see and also from how we designed it, I would agree. But I can't really say whether this was the decisive feature. It might also be that the information about how exponential spread works was decisive. That I can't really say. I just can say that it worked and pretty well, actually.
Okay, folks, so I think we're coming towards the end. I mean, it's very interesting that we have so many studies across the world in these areas at this point. And I mean, one thing that I'm fascinated by the conference is the potential for us to really put more effort into trying to meta-analyze what's happening and also to think about what might have been the implications of the fact that we're often using online panels. I mean, I would say most of the studies I've seen, including the ones I've been involved in myself, have been in that territory. So it would be an interesting thought as we have more time now to actually gather larger scale representative panels. Sorry, there's something noise there. Larger scale representative panels. What will happen there? And I think the other thing, it would be interesting to see that there's so much data now from different countries as to whether it is plausible that cross-country differences could be being generated by these sort of differences in the capacity of different governments to communicate and the strategies that they're adopting. I think I haven't seen any convincing evidence in that direction yet, but it strikes me from today that we've probably got enough data now to even begin to attempt some things like that. But we've come to the end. I would really like to thank the speakers who were all bang on time and really exceptionally professional and interesting talks, and for all of the organizers again for the conference, and all of you for interesting questions all the way through. So let's in whichever way we can, either physically or digitally, just say one last thank you to the speakers. And yes, we'll bring this one to a close. Thank you very much, everyone. Bye-bye.
Thank you.
Thank you for the speaker. Thank you, Liam. Thank you. We will start again at 10 past. Thank you for that final keynote. Okay, I guess we can start again. Welcome back, everybody. It is our greatest pleasure and honor to welcome Professor George Lowenstein for the last keynote speaker of our conference. Professor George Lowenstein is the Herbert Simon University Professor of Economics and Psychology at Carnegie Mellon University. He is the director of the Center for Behavioral Decision Research at Carnegie Mellon and the director of Behavioral Economics at the Center for Health Incentives at the University of Pennsylvania. Professor Lowenstein is a founding pioneer of the field of behavioral economics, and he has published more than 200 articles in top journals in economics, psychology, medicine, and other disciplines. Today we'll talk for about 35 minutes, followed by some questions time for questions. And his talk will bring together two pressing global issues, COVID-19 and climate change. Thank you very much, Professor Lowenstein, for being with us.
Thank you, Matteo. And thanks for organizing the conference. It's great to see lots of familiar faces. So I'm going to talk about connections between COVID-19 and climate change. And obviously there are a lot of connections. There's a lot of parallels between the two problems. And there are some differences. And a lot of really interesting questions that are raised when you think about those connections. One particularly interesting question to me is, it's pretty clear to me that COVID has kind of distracted attention away from climate change in the short term. But what's going to be the long-term effect? One possibility is that COVID is going to turn out to be a kind of a wake-up call. People are going to realize how fragile society is and respond more forcefully to climate change. On the other hand, people might be so burnt out from dealing with COVID that they just want to move on. So I think it's a really interesting question. I'm not going to address that question or the different parallels, the different similarities and differences between the two problems. I'm just going to focus on one very narrow issue. And I'm expecting to finish easily within half an hour. Hopefully there'll be a lot of time for an active discussion at the end. This one question came to my mind when I read a paper that Nick Chater shared with me. He prepared it for the UK Climate Change Committee, and the title is Net Zero After COVID, Behavioral Principles for Building Back Better. So it's about exactly the topic of my talk. And a lot of the stuff I'm going to talk about kind of stems from conversations that I've had with Nick over the last few years. All right, so I'm really going to address two big questions in the talk. One is, now that we can hopefully see the light at the end of the tunnel on COVID-19, what insights can we apply from the experience to the next, arguably actually current disaster that's currently happening? We can see it in the United States right now, and that is climate change. And then I also want to use that question to address a very meta question, which I've been thinking about for over a decade now, which is the question of what's the most useful role for behavioral economics in public policy? Okay, a bit of background about behavioral economics, public policy, and nudging. I've become a bit concerned about nudges, a bit of a nudge skeptic, I would call myself. I'm really concerned that nudges have become synonymous with behavioral economics and public policy. And I think that, as I'm going to argue today, that the potential role of behavioral economics in public policy goes way beyond nudges. And this started with a op-ed I wrote in the New York Times with Peter Ubel in 2010, but since then I've been publishing a bunch of papers making this point. So that's my first concern. My second related concern is that nudges may actually be crowding out more substantive policies. Nudges are, I think some nudges are sometimes treated as a Band-Aid for a problem when much more serious interventions are called for. People feel like if we did the nudge, okay, we've done our bit to deal with the policy. And I have a relatively recent paper with David Hagman and Emily Ho titled Nudging Out Support for a Carbon Tax. Here's a snippet from one of the several studies presented in the paper. We ask people about their support for a carbon tax, and if we just ask them point blank, there's about 45% support for a carbon tax. But if we first ask them about, if we first inform them about a green energy nudge, people really like the green energy nudge, but then after learning about the green energy nudge, their support for the carbon tax declines from about 45% to 26%. This doesn't work for an unrelated nudge. So it really is that people are thinking, oh, with this green energy nudge, that sort of takes care of the problem. So I'm very concerned about that. In recent years, there's just in the last few years, there's been a growing amount of evidence questioning the effectiveness of nudges. There's the paper by De La Vigne and Linos that's gotten a whole lot of attention. And David Laibson, who is one of the pioneers in applying behavioral economics to retirement, gave a keynote at the, not this last, but the year before at the AEA, American Finance Association, at a very big joint luncheon session. The gist of his keynote was that the title of it was "Nudges Are Not Enough, the Case for Price-Based Paternalism." And he talked about how defaults on retirement policies, also, auto enrollment, auto escalation, and so on, even though it seems like they have some beneficial effects, they're just not moving the needle on the retirement savings crisis that we have in the United States. I think the experience of COVID-19 reinforces all of these different concerns. If you look at what types of policies have been effective, I think the best way to think about that question is to compare different countries. And if you compare different nations' responses to COVID-19, this is what I think you find. There are enormous benefits of centralization. And that's true for combating the spread. I mean, look at China. COVID originated in China, and yet China has very, very low number of cases now. And that's in part because China has a kind of a powerful centralized system. Compare that to the US, which COVID hit substantially later, and yet we're really a basket case. If you think about the vaccination that's going on now, the UK is much better than the US. Why is that? In the UK, you've got the national health system. You've basically got a list of everybody in the country who is getting healthcare. And with that system, you can prioritize people and you can call them up and tell them when their time is due. In the US, you just, if you're not in the US, you just can't conceive of how bad the system is here. In Pennsylvania, you have to get on a website and there's a map with little tiny green dots on it, and you click on the dots. You have to, you don't want to click on a dot that's too close to you, like in a city, because the city vaccines are all taken up. So you're looking at distant locations, you click on the dot, maybe one of them says the vaccine is available. You get on the website, you fill out all this information, and by the time you finish the information, you get the message, and you've wasted all your time. You get the message, sorry, it's no longer available. It's just, if you wanted to have a formula to burn a huge number of people's time for no purpose, you couldn't design a better system. So centralization is all important. Related to centralization, I mean, I think even better would be some kind of world centralization. I think one of the things that we've learned from COVID-19 is another lesson about how interconnected the world is. You can try to deal with a problem in one country, but if you leave it uncontrolled in other countries, the virus is going to mutate and come back and bite you. And the second major insight from comparing different nations' responses is the need for rapid and dramatic response. The countries that have delayed have been the disasters. The countries that plunged in with pretty heavy-handed policies are the ones that have done really well. Again, China is a good illustration of that. And the bottom line, in my view, is that nudges just aren't going to hack it for a problem of this magnitude. Even if nudges won't hack it, I still think behavioral science is all important. And that's kind of my general line of thinking these days. We don't want to restrict behavioral economics or behavioral science to nudges when it comes to policy. I think nudges, among all the other insights that nudges can contribute, it helps to explain why so many countries, including the US and Great Britain, have botched COVID so badly. And it specifically sheds light on why policymakers in countries with where policymakers are accountable, like democracies, liberal democracies, have been so reluctant to take the needed drastic measures. And I'm going to argue that to understand why the failure to take the necessary measures, it's really important to take account of the behavioral phenomenon of adaptation. So by adaptation, Shane Frederick and I years ago, we wrote a chapter titled Hedonic Adaptation. We give the definitions at the beginning. Adaptation is any action, process, or mechanism that reduces the effects, which could be perceptual, physiological, attentional, motivational, hedonic, and so on a constant or repeated stimulus. And hedonic adaptation, which is the focus of our chapter, is processes that attenuate the long-term emotional or hedonic impact of changes in circumstances. And these impacts could be positive or negative. Basically, when things change, you have a hedonic response to them, but if they remain the same after that, the response tends to diminish. Here's the steps of the argument I'm going to make today. First, people rapidly adapt to changing circumstances. Second, people underestimate their own rate of adaptation and learning by learning to cope with their new situation. And the consequence of that is that people overreact in a negative way to changes because they don't appreciate that they will adapt surprisingly fast. And the third point is that policymakers are subject to exactly the same bias. And this bias, this underappreciation of adaptation, discourages policymakers from taking the types of bold initiatives that are required to deal with problems like COVID and like climate change. That's my whole argument today. In the remainder of the talk, I'm going to document these phenomena and discuss their applicability to climate change. All right, point one, people rapidly adapt to changing circumstances. In our review piece, we talk about how hedonic adaptation is a virtually ubiquitous process. People can adapt remarkably well to health conditions like disabilities as dramatic as paraplegia, even quadriplegia. And people can also adapt to horrible circumstances like solitary confinement. I mean, solitary confinement changes people, and that's exactly because they adapt to it. But people in solitary confinement are not as miserable as you'd expect them to be. They're just altered. They become very antisocial and so on. We talk in the paper about how adaptation involves a range of mechanisms. For example, if you think about paraplegia, after somebody becomes paraplegic, they're going to change their daily activities. Obviously, then they might exercise less, they might read more, things like that. They're going to develop there's going to be physiological changes like new musculature on their upper body to compensate for the loss of their use of their lower body, technological aids like wheelchair lifts and so on, and changes in identity. They might, if they want to have high self-esteem, they might come to view themselves as a high-functioning paraplegic, something like that. Adaptation is closely related to and often causally connected to learning. This is a point that Nick Chater makes in his paper. This is a figure from his paper showing learning in different contexts. One of the first studies of learning documenting the so-called power law of learning, or the power law of practice, was with mirror tracing. Snoddy, 1926, it goes back that far. There was a study of cigar rolling, I think that was in Cuban cigar factories. There have been studies of producing liberty ships during times of war and so on. But basically, organizations and individuals tend to learn surprisingly rapidly. Learning is the most rapid early on, and then it tends to slow down a bit. That's the power law. In his paper, that should be 2021, not 2001, Chater writes, COVID-19 and the lockdowns and other restrictions imposed by governments around the world in response to the virus has required a huge amount of behavior change. Individuals, businesses, and governments have, despite great hardship and disruption, responded remarkably rapidly. And he says it's not really surprising given all the research that we know about dealing with learning. One factor that speeds adaptation is certainty. This is something that I've done research on in a study with 3 co-authors. The title of the paper is Happily Hopeless, Adaptation to a Permanent but Not to a Temporary Disability. We looked at patients who were receiving either a permanent or a potentially reversible colostomy. That's like a bag, your gut empties out into a bag. And we interviewed them at 3 times, a week after they were released from the hospital, a month after they were released, and 6 months after they were released. And here's what we found. We looked at their well-being using 2 different scales. This is their well-being using a 1 to 7 life satisfaction scale. And if you look at 1 week after the operation, the people with the, as you might expect, the people with the potentially reversible colostomies are a bit better off than the people with the permanent ostomies. But if you track them over time, an interesting pattern emerges. The people with the potentially reversible ostomies get more and more miserable over time, and the people with the permanent ostomies improve in happiness and life satisfaction until they're kind of indistinguishable from healthy people. And what this shows, and what we claim in this paper, is that it shows that when people know that something is irreversible, that it's certain that they can adapt to it. There's a lot of both nonfiction and fiction that talks about this phenomenon. This is a study, this is a book, The Desert and the Sea, 977 Days Captive on the Somali Pirate Coast. Quote from that, Bashko and Abd Nasser, these are 2 of his captors, both mimicked my yoga poses like housewives watching a weight loss video. Through these improved classes, they became my sahibs in the pirate villa. Whenever I needed something, they were the guys to ask. Bashko, in particular, kept my hope alive with rumors of negotiations. He made it sound as if I would go free in a matter of days. Of course, I was happy to believe him, but then hope is like heroin for a hostage, and it can be just as destructive. This is from a quote about the same thing from a book. This is a novel by Lena Anderson titled Willful Disregard. In this novel, the protagonist falls in love with this very mediocre artist, becomes absolutely obsessed with him. And it's a really interesting book about obsession. But anyway, during the course of the book, she writes, everything in existence wants to live, and hope is no exception. It is a parasite that lives and thrives on the most innocent of tissue. Its survival lies in a well-developed ability to ignore everything that is not favorable to its growth while pouncing on anything that will feed it and help it to live on. Then it ruminates on these crumbs until every trace of nourishment has been extracted from them. Now hope was gnawing with divine frenzy. She continues many pages later, hope has to be starved to death if it is not to beguile and bedazzle its host. Hope can only be killed by the brutality of clarity. What does this have to do with public policy? In my view, it says that policies, if they're implemented decisively with no perceived chance of reversal, will be adapted to more rapidly. That people will adapt more rapidly to a policy if they don't see any chance of it being reversed. Point 2, people underestimate their own rate and degree of adaptation or learning. Diverse research shows that healthy people believe they'd be more miserable with serious health conditions than those who have them report that they are. People think they'd be really miserable if they were disabled, but disabled people say that they're not all that bad off. There's tons of research showing this. This is egocentrically, this is a study that I was part of, ignorance of hedonic adaptation to hemodialysis, a study using ecological moment assessment. It found that dialysis patients experienced positive moods the majority of their waking hours. Yet healthy people predicted that dialysis patients would experience unpleasant moods the majority of the time. In another study, Disability and Sunshine, can hedonic predictions be improved by drawing attention to focusing illusions or emotional adaptation? We test 2 major explanations for the discrepancy. Either a focusing illusion is the idea that we think that we'll be more miserable with a health condition because our attention is focused on the health condition itself. And second, underprediction of adaptation. we ran a whole bunch of studies testing focusing illusion. We kept trying to defocus people by reminding them of all the things that would be unchanged, or even better if they became disabled. That had no impact on their estimates of the quality of life of patients with disabilities. Underappreciation of adaptation, on the other hand, received very strong support. What we did was we gave people a broad adaptation exercise. We asked subjects to remember a life experience that was emotionally difficult for them. And then we asked them to think about whether their emotions changed over time and whether they ended up feeling worse, about the same, or better than they would have predicted after they had right after the experience. And this substantially, significantly, and substantively raised their estimates of the patient's quality of life. So strong support that the reason people think that patients are worse off than they are, that disabled people are worse off than they are, is because they don't appreciate adaptation. I've run a bunch of different studies looking at underprediction of learning. This is an old study with Darren Billeter and Kalra. We had people do a task repeatedly. It was in one case, it was mirror tracing, knot tying, playing the Guitar Hero, which was popular at the time. And we asked them to predict their own performance either before they had any experience of the task, right after they had initial experience, or after each round of learning for future rounds. And here's what we found. This is with mirror tracing. This is the actual learning. They got better, dramatically better at mirror tracing from round to round. You can see that here. Before they did any mirror tracing, they thought they would be much better at it than they turned out to be. That's this point here. But they also massively underpredicted their rate of learning. The moment they had a little bit of experience with mirror tracing, they became much more pessimistic. That's down here. We call that the all thumbs effect. And so they became much more pessimistic. And of course, they were, not surprisingly, they were about correctly calibrated with their first round performance, but they continued to dramatically underestimate their learning over time. And this is the pattern that we observed in all of the different studies. I've been doing another set of mirror tracing studies with Sammy Horn, a graduate student in our program. And we've developed a computerized mirror tracing task, and participants are paid for each image that they complete accurately. We give them 9 short rounds of the task. The image complexity remains the same, but they get a different image, which is randomly chosen for each screen. And participants are incentivized both for their performance and for their predictions of performance in the following 3 rounds. So they predict their performance 3 rounds in the future. Here's what we find. This is the actual learning curve on the mirror tracing task. This is before they have any experience with that. You can see again, they're overconfident before they have the experience. The moment they have experience, their confidence drops dramatically. And we generally see that they both underpredict their performance and they dramatically underpredict the speed with which they will learn to get, the speed with which they will get better at the task. That's very similar to our earlier findings. We're interested in whether this is a paper that we're hoping to aim at economics, and we're interested in whether this makes a difference for material questions. So we provide people with a scheme for a late round, round 10, and either they can just get a straight payment of 5 cents per image for every image that they complete, or in the high payment scheme, we'll give them 10 cents per image, but they're only going to get paid if they do 3 more images than they did in round 1. So the idea is if people underpredict their own learning, they're going to pick the low payment scheme and miss out on the payments because they're going to worry that they're not going to be able to complete enough images to get paid in the high payment scheme. And here are some very preliminary results, very small n. We're in the process now of replicating it with a large n. But you can see that when people make a choice early, they're much more likely to choose the low payment scheme. And when they make a late choice, they have a much better appreciation of the fact that they're going to get better at the task, and then they're much more likely to choose the high payment scheme. What are the consequences for policy? When policy changes are introduced, people who are affected are likely to be especially upset because they fail to predict how quickly they will adapt and they'll learn how to deal with a new environment. This is it's a type of empathy gap. In this case, it's a hot predicting cold empathy gap. It's very analogous in my view to addicts who fail to quit because they're craving and they don't appreciate how quickly the craving would dissipate if they stopped taking the drug. I think it's also analogous to people who impulsively commit suicide. A lot of suicides are impulsive because when you're depressed, it's really difficult to imagine feeling better. I think when you are facing some kind of a new policy that you have to adapt to, your initial reaction is to be very upset and to think that your initial reaction will last much longer than it will. And the third point is that policymakers are the subject to the same bias, which discourages bold initiatives. So Chater writes, one implication of the power law is that individuals, businesses, and governments focused on the short term are likely often to be unwilling to switch to better ways of working. The initial cost of switching will appear daunting, creating a friction which will impede change. That's kind of the main, that's a cute cat, Nick. Impede policy change. I think this is illustrated by policies proposed by behavioral economists to deal with vaccine hesitancy. A lot of behavioral economists have been very focused on relatively subtle interventions, such as information campaigns to increase trust. Like if we can get people to trust in the vaccine, they'll get vaccinated. My own view is that far more heavy-handed approaches are called for. Some of these approaches are articulated in a recent piece I wrote with Kevin Volpe and Alison Buttenheim. Much more heavy-handed approaches like restricting access to public and workplaces by people who refuse to be vaccinated. What about climate change? So far, in my view, behavioral economics may not have played a particularly constructive role when it comes to climate change. I think behavioral economics has tended to support nudges, which are nano-sized investments that produce medium-sized gains. And as I talked about when I referred to our paper, nudging out support for a carbon tax, I think it's possible that nudges have the existence of nudges have discouraged more substantive interventions. So the meta point of my talk is that behavioral economics can and should support not only nudges, but also the needed large investments, the more dramatic policies with much larger gains that are so sorely needed. We all know that a carbon tax is really the only answer to climate change, perhaps, or a cap and trade, which is almost equivalent. Carbon tax would cut down on extraction and use of fossil fuels. It would accelerate the development of alternative sources of energy, transmission, and storage. Behavioral economics, and specifically consideration of adaptation and learning, suggests that a carbon tax would be much more rapidly and broadly accepted than policymakers might fear. When it comes to climate change, I think adaptation is a double-edged sword. On the downside, adaptation weakens our response to severe problems if they're ongoing. So climate change, it keeps on changing sort of relatively gradually, and we keep adapting to the changes that have happened. And that's very bad in terms of contributing to the lack of response to climate change. A guy named Dubos wrote in a 1965 book titled Man Adapting, this very adaptability enables us to become adjusted to conditions and habits which will eventually destroy the values most characteristic of human life. I think that was really a prophetic observation. On the upside, adaptation can enable the kinds of substantive policy responses that are so desperately needed. These policies can and should be implemented because people will adapt to them surprisingly quickly. The problem is this upside won't be realized if policymakers fail to appreciate the speed and adaptation. The speed and extent of adaptation, sorry. Behavioral economics has a lot of other non-nudge insights to contribute to climate change and COVID. It helps to explain why climate change has not so far. So we have I think we have a really good economic explanation for why climate change is so difficult to deal with. It's the free rider problem. But economics doesn't explain why there's so little concern, kind of public concern about climate change. And I think behavioral economics can contribute to that. It helps to explain why climate change has not so far evoked the concern it warrants, and that some of the reasons are adaptation, lack of tangibility, time discounting, solution aversion, information avoidance, biased information processing, political polarization, and so on. So behavioral economics has a lot of light to shed on that. And second, I think behavioral economics can contribute important insights into how a carbon tax could be implemented. For example, whether the tax is best implemented upstream, like on energy producers, or downstream on consumption. It could also help to contribute insights into how the carbon tax will generate a lot of revenue. What should be done with those revenues? One possibility would be to use them to, for example, solve the retirement crisis. And finally, the behavioral economics could contribute insights into issues like such as whether the tax should be segregated or integrated from product prices and how it should be framed. So my bottom line is behavioral economics and public policy should be about more than nudging. Behavioral economics should support and complement the substantive policies that we critically need to deal with very serious problems like the pandemic and like climate change. Let me end with a quote from Nick from the same paper I keep on referring to. The main lesson of COVID is that adaptation can occur surprisingly quickly and much more quickly than we typically anticipate. Changes to ways of operating which are initially slow, costly, and inefficient may become highly effective over time. This is an important motivation for enhanced short and medium-term government policy support, where opportunities to move to better ways of living and working that may be socially and economically highly cost-effective in the long term. All right, I will stop there and got lots of time for discussion. So hopefully there are a lot of questions or a lot of points that people want to make.
Thank you very much, George, for the very fascinating and inspiring talk. We do have quite a lot of questions, which is good. So shall we start with the question raised by the panelists, and then we can open up to the rest of the audience. I think there is one question that was posted by Nico Lassetra. Lassetra is, I think, he's still online. So maybe, Nico, if you want to jump in directly. Thank you.
Hi, George. Nice to see you. One question I wanted to ask toward the beginning of your talk. So you showed some result about people preferring or crowding out from a more constraining solution, for example, to climate change, like carbon tax, toward nudges, right? Especially when they can see both, and eventually they say, oh, you know what, the nudge is nicer. What if we were able to provide evidence of what works and what doesn't? Would this reduce this crowding out effect? Because I mean, on the face of it, if something is not that constraining, you know, people might like it better. But what if we show them that it doesn't work or it works less? So there is some there are some studies today that confront people with evidence and see how they update, for example, from the prior.
I just want to say I did not plant Nicola with that question, but I'm very happy to get it. The last study in the paper actually deals exactly with that.
Oh, great.
We inform people about the small effect of the nudge, and we also try to make the carbon tax seem less painful by emphasizing that there's going to be revenue that's going to be used in some beneficial way. And when we do that, we get a dramatic increase in support for the carbon tax. And I think not only does this help to kind of provide some insight about how to build support for more substantive policies, but we also use it to support the explanation that we give for the crowd out effect, which is that people are grasping on, this seems like a much easier, lower cost intervention. And so that makes it very attractive to people. But when you undermine their ability to do that, then their support for the carbon tax dramatically increases. So yes, the last study in the paper deals exactly with the issue that you raised.
Thank you.
Thank you. Yeah, so there are quite a lot of questions around one of the first issues you mentioned at the beginning, the centralization versus decentralized systems. But I would like to take the advantage of, I see Professor Kevin Volpe online posted a question on the lack of centralization of responses, for instance, about vaccine distribution on PP. You want to come in?
Oh, sure. Thank you. Well, George, I thought it was a great talk and you covered a lot of really good points. One point which I think relates to some of what you've written about in the past that could be highlighted more is the role of various strategies beyond centralization, like the use of strong negative incentives for non-compliance with protocols and the role that plays both as a signaling device and in fact in penalizing people. But the question I want to ask you is that one challenge for academics is that we're rewarded for mechanistically clean studies that typically focus on elucidating a single mechanism. But what situations like COVID or climate change call for are arguably a range of complementary approaches deployed simultaneously. And as others have noted in the chat, there are a variety of contextual factors around social norms and culture that may increase or decrease the effectiveness of any of these interventions, either separately or together. How would you suggest, as you think about encouraging the field forward, how do we reconcile this difference between what academia rewards and expects and the nature of these problems like COVID and climate change, which clearly are not looking, where a single mechanistically elegant approach is not likely to solve the problem?
Mm-hmm. Yeah, it's a really, really great question. I mean, I think you're specifically talking about experiments, because if we're talking about non-experimental studies, we have a lot of different countries that have tested different approaches and that have different characteristics and have tried things out at different points in time. So we do have some ability to address the big questions, like, for example, the consequences of centralization. I do think that some of these different types of interventions, like can be tested with kind of stylized experiments, like more lab experiments. Like right now, I've been talking to both Nick Chater and Samantha Horn about running some kind of stylized lab studies to show that policymakers in the lab are reluctant to impose dramatic policies because they overestimate the group reaction to those. So I think it's possible to explore some of these in kind of stylized lab studies. But I also think that we need to be, I completely take your point, but I think we need to be really focused on trying to find venues in which we can test more dramatic types of interventions. Like one thing I notice in the nudge movement, it's really difficult to get people to do interventions that, for example, require human intervention, or that require like humans to take action. I mean things like nurses or something like that, or interventions that require reprogramming of systems. And it's generally pretty easy to get people to change like things like text messages, phone calls, and so on. And I think there's a little bit of a tendency for us researchers to adopt a kind of a drunk under the lamppost approach, which is to do things that are relatively easy, feasible, but are unlikely to have a very big impact. And maybe a smaller number of studies looking at much more dramatic interventions would end up being more useful. But yeah, it is a great question. And I agree with you that both the constraints and the rewards, the constraints on academia and the rewards in academia do tend to favor relatively small scale types of interventions. Thank you. Good to see you.
Thank you. Yeah, before moving to a different set of questions, I think there is also a point raised by another panelist, Professor Don Roth, that actually there are also risks in a centralized system. He pointed to the example of Tanzania as the worst disaster due to central leadership. I don't know whether, Don, you want to elaborate on this? Yeah.
Well, sure. Thanks, Matteo. I mean, it does seem to me that one could overstate the centralization point. I'm sure George recognizes the heterogeneity of national responses, but it seems to me where centralization specifically is concerned, what we actually get is extreme variance, right? We get both some of the best the most effective cases, but also the very least effective cases, right? Tanzania is indeed at clearly the most disastrous response on earth to COVID. They're actually not vaccinating anyone. And that's because the president's a lunatic.
Yeah. Well, one of the lessons I think that I didn't list because it doesn't fit with the meta point that I'm trying to make in this talk, but clearly another thing that we've learned from the pandemic is the importance of good leadership. And that, and I think good leadership interacts with centralization. But and like centralization with bad leadership is probably the worst of all worlds. And I think these are the types, going back to Kevin's question, these are the types of issues that could potentially be looked at in a kind of observational, correlational study comparing different nations' responses, the success of different nations' responses. But certainly centralization by itself is not the formula. Like, thank you.
Thank you. Yeah. So we can move to another set of questions on adaptation. And there is a question by Professor Sandra Polania Reyes on the individual's ability to adapt as different from the family or the household ability to adapt. I don't know whether you can talk directly if you want, or otherwise I can read the question.
Yeah, I mean, I think that as you move to larger social units, you introduce new types of adaptation. So you always, like, if you look at a family consists of individuals, and the individuals can each adapt in their own way. But then the family there's also a potential for the family to adapt. So if you think about COVID, for better or worse, a lot of families have adapted in the sense that one person has continued to work and another person has stayed home and taken care of kids, things like that. Families have adapted have adapted in the same way as individuals. And then if you look at larger entities like states or cities or nations and so on, new forms of adaptation come into play. But still, all of the smaller scale forms of adaptation are still going on. Sandra, I see that you're on. Do you want to elaborate on your question?
Yes, or on your answer, especially because adaptation just happens anyway, right? I mean, all humans are alive, so we are adapting to whatever comes. It's very difficult then for me to think how to falsify adaptation. How can we actually scientifically approach to it? If in this case, for the households, for example, those who are still facing or have now a permanent negative shock, and they make these decisions of leaving jobs, the negative effects of this policy are now increasing over time, and well, they or disappear. These households will disappear. So we can say that they will adapt or not. But then how we approach, what do we mean, or how do we define adaptation in those cases then?
Yeah, I mean, I think this is something I've been thinking about quite a lot in kind of a larger context. I mean, I think if you look at affluent middle-class people in this country, in the United States, versus poor people's lives are much more brittle. It's much more difficult for them to adapt to change than affluent people. And I think a kid gets arrested, a poor kid gets arrested, and they're not going to get any good legal representation. They're going to end up in jail with a criminal record, not to be able to get a job, and so on. Just produces a downward tailspin, whereas a more affluent family can protect them from these consequences. So I think a system that is less brittle is a system that's more adaptable. And it's really important to think about adaptation when you're designing systems, to think about designing systems that are not brittle. I've also thought about this in the context of drugs. I think my own view, this is kind of very grand, my own view of life is you're sort of dealt these cards. You're dealt a brain and a kind of a personality and a family setup and so on. You come into the world and you try to make do the best that you can with the cards that you're dealt. And a whole lot of life is just adapting to the cards we've been dealt. And then sometimes we're provided with some kinds of shortcuts, like depression drugs or ADHD drugs, things like that. And of course, these drugs are good for some people. I'm not saying across the board these are bad things, but I think sometimes taking things like antidepressives or stimulants can impede people's process of figuring out how to adapt to who they are and what their situation is. And I think that's true at the individual level, but it's really important when we're thinking about all sorts of different problems to think about trying to what will be the effect of an intervention on people's ability to adapt, people's propensity to and ability to adapt. And that's true at the public policy level as well.
Thank you. Thank you. I think we also have another panelist, Professor Phil Fan from the Johns Hopkins University, who has a question.
Thank you, Matteo. So George, thank you for a very thought-provoking talk. I'm sure you don't mean to imply this, but when you talked about adaptation, I got the sense that there is sort of a normatively positive tone about it, that people encounter difficulties, they adapt to overcome these difficulties. But I think one has to also think about the conditions under which maladaptation occurs. So something like a centralized edict, say for lockdowns. And we know now, I think earlier on ignored the fact that there are individuals that suffer from these things. So you have increased rates of depression, of suicide. I mean, these are well documented. So I wonder if you have any thoughts about this, because you sort of connected the findings from behavioral economics to a policy recommendation, and there seems to be sort of a very big leap. And I think there are lots, as they say, lots of details and heterogeneity in populations that would suggest that perhaps a more nuanced, I guess, approach may be more, or even a localized approach may be more useful. In any case, thank you.
Yeah, well, let me just go back to a point I made in my talk, which is that adaptation is not always a good thing. Like adaptation can lead us to tolerate and tolerate and adapt and accommodate situations that should be intolerable, like climate change, for example. I suppose it's also possible that maladaptation can occur. You can adapt in ways that are counterproductive. I mean, I think your point overlaps with the point that Dawn made earlier about centralization. And looking at this this problem after the fact, centralization does seem to have been a good policy where it's been implemented effectively. But centralization certainly isn't always the best policy for all types of problems. Although I do think that a whole lot of the problems in the United States are traceable to lack of centralization. Things like, for example, property taxes, that schools are funded with property taxes. So the schools are better funded in richer areas. Whereas if you contrast that with like France, which has famously good schools, where the schools are funded at the federal level, I think that this is not the only case in which there are huge benefits to centralization. The same thing with taxes. The states in the United States compete with one another to lower corporate taxes to attract corporations. The ultimate consequence is kind of a race to the bottom. And so I guess I'm rambling a little bit. I mean, I think in general, I think we, especially in the United States, we don't go nearly far enough down the centralization road. We need much more centralization than we have to deal with a lot of our most difficult problems. But certainly there are situations in which centralization is inappropriate. And if the people who are doing the centralizing are incompetent or corrupt, that's of course going to lead to a terrible outcome.
Thank you.
Thank you. Yeah, so also this discussion has also raised some other questions that have been posted about the limit of adaptation, one by Daniel Basfian on the not always beneficial effect of adaptation, for example, in the case of ignorance or mass sufferings, psychic numbing, and the other one by Johannes Lose about the climate change issue. Perhaps what we can is to ask a final question, and going back to the beginning of your talk, there is a question by Leonard Leitz on the limits of nudges. So do you think it seems to ask, do we need more reduction of sludges, the evil part of nudges, but do we also want to argue more in favor of a stronger focus on non-behavioral policies?
I guess the big point I'm trying to make is that as behavioral economists, I don't think we want behavioral economics to become synonymous in the public or the academic mind with small scale interventions like nudges. I think for lots of different problems, much more dramatic types of interventions are called for, things that involve changing prices, taxes, subsidies, and bright line restrictions and so on, mandates and so on. And that I think behavioral economics has a very key role to play in informing whether and how these types of other policies should be implemented. And so I'm just trying to I'm not trying to attack nudges, even though it may sound that way, but I'm really instead trying to say that the scope of behavioral economics should be much greater, and that we don't want behavioral economics to become viewed as synonymous with nudges. That's really the big point I want to make. And so I was using adaptation as just one example, adaptation and COVID, climate change as one example where I think much bigger interventions are desperately needed. And yet I still think that behavioral economics has a very central role to play.
Thank you. And I think that this is a very exciting message and note to finish the conference with. Thank you very much, Professor Lowenstein, for the very inspiring
and the organizers.
Talk, and everybody for the discussion. And I think it's also the right moment to thank Professor Lowenstein and also our other keynote speakers, Professor Sunstein, Katy Milkman, Sunita Shah, all the panelists, and of course all the contributors in the video presentation, but also to the more than 50 video presentation that has been posted. Thanks to Jamie for all the work, the department of the John Hopkins Business of Health Initiative, and also the Department of Psychological and Behavioral Science for the support. All the other supportive networks, the Behavioral Experiments in Health Network, the LSE Behavioral Lab, the Periscope Grant. But of course, thank you to the scientific committee, fantastic work for selecting the paper, and all the attendants that are still online. Thank you very much for all the questions and for the fantastic discussion. Thank you all, and thank you, Mario.
Thank you, Matteo. This collaboration between Johns Hopkins and the London School was great in my experience, hopefully the first of many more. Thanks again, everybody.